Hi there, preparing for D441 OA exam can feel overwhelming, but it doesn't have to be. Stick with us and we're going to help you with it. We built a free question bank for the D441 OA exam. Preparing for an OA is no joke, so our guides and practice questions are completely free. In this video, we'll be tackling questions across 5 key areas: vancomycin reactions, anticoagulant therapy, opioid safety, lithium toxicity, and insulin administration. So let's get into it. 1. A patient receiving vancomycin intravenously develops facial flushing, intense pruritus, and a widespread red rash across the face and upper extremities shortly after the infusion rate was significantly increased. Which adverse condition should the nurse suspect first based on these presenting clinical findings? A. Anaphylactic shock reaction. B. Normal expected drug response. C. Redman syndrome. D. Drug-induced hepatotoxicity. Can you guess the answer? Correct answer C. Redman syndrome. Explanation: option C is correct because Redman syndrome results from rapid vancomycin infusion, causing flushing, pruritus, and a red rash on the face and extremities due to histamine release, not a true allergy. Option A is incorrect because anaphylactic shock typically involves tachycardia, angioedema, wheezing, and significant difficulty breathing, which are severe systemic responses distinctly different from the flushing and pruritus pattern described. Option B is incorrect because while minor burning at the intravenous site can be a normal side effect of vancomycin administration, widespread facial flushing and a red rash are not considered expected normal responses. Option D is incorrect because hepatotoxicity presents with jaundice, elevated liver enzymes, and abdominal symptoms rather than the sudden onset of facial flushing and red rash associated with a rapid infusion. Alright, let's get right into the concept behind this question. When a patient is receiving vancomycin intravenously and the infusion rate gets cranked up too fast, something called Redman syndrome can happen. This is not a true allergic reaction. What actually occurs is a massive histamine release triggered by the rapid infusion speed. That flood of histamine causes the classic triad you need to recognize: facial flushing, intense itching or pruritus, and a widespread red rash across the face and upper body. Now, why not anaphylaxis? Because anaphylactic shock looks very different. You would see wheezing, angioedema, severe breathing difficulty, and tachycardia. Those are absent here. A normal drug response might include some minor burning at the IV site, but a full red rash across the face and chest is not normal. And hepatotoxicity, that would show up as jaundice, elevated liver enzymes, and belly pain, not a sudden red rash. Here is a WGU D441 OA exam tip for you. When you see a question pairing vancomycin with facial flushing, pruritus, and a red rash, especially after a rate increase, the answer is Redman syndrome every time. Quick recall hook: fast van equals Redman, fast vancomycin infusion equals Redman syndrome. 2. A nurse is comparing 2 patients on vancomycin therapy. Patient A has flushing with hypertension from a rapid infusion. Patient B has hives, tachycardia, and wheezing. Which clinical reasoning best explains the key difference between these 2 distinct patient presentations? A. Patient A has Redman syndrome and patient B has a true allergic reaction. B. Both patients have Redman syndrome. C. Patient A has nephrotoxicity and patient B has ototoxicity. D. Both patients have true allergic reactions. Do you know the answer? Correct answer: A. Patient A has Redman syndrome and patient B has a true allergic reaction. Explanation: option A is correct because Redman syndrome from rapid infusion causes flushing, pruritus, and hypertension, while a true allergic reaction presents with hives, tachycardia, angioedema, and respiratory symptoms like wheezing. Option B is incorrect because Redman syndrome does not typically present with hives, tachycardia, and wheezing, which are hallmark signs of a true allergic reaction. requiring immediate different clinical intervention and management. Option C is incorrect because nephrotoxicity involves rapid kidney function loss, and ototoxicity involves tinnitus or inner ear damage, neither of which matches the skin flushing, hives, or respiratory symptoms described in these patients. Option D is incorrect because patient A displays the classic pattern of red man syndrome from rapid infusion, specifically flushing and hypertension, which is a histamine-mediated reaction and not a true immune-mediated allergy. This next question requires you to think like a clinical detective, comparing two very different patient responses to the same drug. Patient A has flushing and hypertension after a rapid vancomycin infusion. Patient B presents with hives, tachycardia, and wheezing. These are two totally separate reactions. Patient A is experiencing red man syndrome, which is a histamine-mediated response caused by infusing vancomycin too quickly. The hallmarks are flushing, pruritus, and sometimes hypotension. The fix is slowing down the rate. Patient B, on the other hand, is showing textbook signs of a true immune-mediated allergic reaction. Hives, a racing heart, wheezing, those point to the body mounting an actual immune response, which is a completely different emergency. Nephrotoxicity and ototoxicity are organ damage concerns, not skin and respiratory symptoms, so that pairing makes no sense here, and saying both patients have the same reaction ignores the completely different clinical pictures. Here's a WGU D441 OA exam tip for you. When comparing two patients on the same drug with different symptoms, line up each symptom set separately. Flushing plus hypertension after rapid infusion equals red man syndrome. Hives plus wheezing plus tachycardia equals true allergy. Quick recall hook. Flush means rush, hives mean allergy lives. 3. A nurse is monitoring a patient 30 minutes after starting a vancomycin infusion. The patient reports ringing in the ears and has decreased urine output. Which pair of adverse effects should the nurse recognize as the most likely complications developing in this situation? A. Red man syndrome and hepatotoxicity. B. Allergic reaction and hypertension. C. Nephrotoxicity and red man syndrome. D. Ototoxicity and nephrotoxicity. Can you guess the answer? Correct answer D. Ototoxicity and nephrotoxicity. Explanation: Option D is correct because tinnitus, or ringing in the ears, is a hallmark sign of ototoxicity from vancomycin, and decreased urine output strongly suggests nephrotoxicity, indicating rapid kidney function decline in this patient. Option A is incorrect because red man syndrome presents with flushing and pruritus from rapid infusion, and hepatotoxicity involves liver damage, neither of which is indicated by ear ringing or decreased urine output. Option B is incorrect because, while hypotension can occur with vancomycin, the specific symptoms of tinnitus and decreased urine output are classic indicators of ototoxicity and nephrotoxicity, not an allergic reaction pattern. Option C is incorrect because although nephrotoxicity fits the decreased urine output finding, red man syndrome involves flushing and rash from rapid infusion and does not cause tinnitus, making this combination only partially correct. Let's break apart what the body is telling us in this scenario. The patient is 30 minutes into a vancomycin infusion and reports ringing in the ears. On top of that, urine output has dropped. These are two separate organ systems sending distress signals. Ringing in the ears, called tinnitus, is the signature warning sign of ototoxicity. That means the drug is causing damage to the inner ear structures. Decreased urine output signals that the kidneys are struggling, which is the hallmark of nephrotoxicity. Vancomycin can hit both of these organ systems, so when you see ear symptoms and kidney symptoms together on the same patient, you pair ototoxicity with nephrotoxicity. Red man syndrome does not cause tinnitus, it causes flushing and rash. Hepatotoxicity hits the liver, not the ears. An allergic reaction would bring hives and wheezing, not ringing ears and low urine. Here is a WGU D441 OA exam tip for you. When a question gives you ear ringing and decreased urine output on a vancomycin patient, match each symptom to its organ. Ears equal ototoxicity, kidneys equal nephrotoxicity. Quick recall hook, ears ring, kidneys sting, both are vancomycin toxicity targets. 4. After administering vancomycin through an intravenous line, the nurse should remain with the patient and monitor for swelling, pain, and redness at the infusion site for a specific required observation period. What is the minimum monitoring time recommended following vancomycin administration? A. 15 minutes after completion, B. 30 minutes after administration, C. 60 minutes after infusion ends, D. 2 hours after the dose. What do you think is the answer? Correct answer, B. 30 minutes after administration. Explanation: option B is correct because standard nursing protocol requires monitoring a patient for at least 30 minutes after vancomycin intravenous administration, specifically watching for swelling, pain, redness, and signs of adverse infusion reactions. Option A is incorrect because 15 minutes is too short an observation period to adequately detect developing adverse reactions from vancomycin, which may present with delayed onset of swelling, redness, or infusion-related complications. Option C is incorrect because while extended monitoring is sometimes appropriate for high-risk patients, the standard recommended minimum observation period after vancomycin administration is 30 minutes, not a full 60 minutes of monitoring. Option D is incorrect because a 2-hour monitoring period after vancomycin infusion is not the standard recommended timeframe and would unnecessarily extend the observation beyond what current nursing guidelines for vancomycin administration require. Here is a straightforward but testable nursing protocol question. After vancomycin finishes infusing intravenously, the nurse needs to stay with the patient and watch for trouble signs at the infusion site, swelling, pain, redness. The question is asking about the minimum monitoring time. Standard nursing protocol says 30 minutes. 15 minutes is too short. Reactions to vancomycin can take time to develop, and cutting the observation window that tight means you could miss swelling or redness that shows up at the 20-minute mark. 60 minutes might be appropriate for high-risk patients, but it is not the standard minimum. 2 hours goes well beyond what guidelines call for and would tie up nursing resources unnecessarily. The answer is 30 minutes after administration. Here is a WGU D441 OA exam tip for you. When a question asks about the minimum monitoring time after vancomycin IV administration, the answer is always 30 minutes. Do not overthink it. Quick recall hook, Vance watch equals 30 minutes no less. 5. A patient receiving vancomycin develops flushing, a red rash, and mild hypertension. The nurse recognizes this as red man syndrome. Which nursing intervention should be the priority action to manage this infusion-related reaction and prevent further escalation of symptoms? A. Slow the infusion rate immediately. B. Administer epinephrine right away. C. Discontinue the drug permanently. D. Apply cold compresses to skin. What do you think is the answer? Correct answer, A. Slow the infusion rate immediately. Explanation: option A is correct because red man syndrome is caused by histamine release due to rapid vancomycin infusion, so slowing the infusion rate is the primary intervention that directly addresses the underlying cause and prevents worsening. Option B is incorrect because epinephrine is reserved for true anaphylactic allergic reactions involving airway compromise, and red man syndrome is a histamine-mediated response to rapid infusion, not a true immune-mediated allergic emergency. Option C is incorrect because red man syndrome does not require permanent discontinuation of vancomycin, as the reaction is rate-related and can typically be managed by slowing the infusion and administering antihistamines before future doses. Option D is incorrect because applying cold compresses addresses only the superficial skin symptoms and does not treat the underlying cause of red man syndrome, which is the excessive histamine release triggered by a too rapid infusion rate. So the patient is showing flushing, a red rash, and mild hypotension during a vancomycin infusion, and the nurse already recognizes it as red man syndrome. Now the question is about the priority intervention. Since red man syndrome is caused by histamine release triggered by infusing the drug too fast, the fix targets the root cause. Slow the infusion rate immediately. That is your number one move. Why not epinephrine? Epinephrine is the big gun reserved for true anaphylactic emergic, where the airway is closing. This is not anaphylaxis. This is a rate-related histamine dump. Permanently stopping the drug is overkill because red man syndrome is manageable. You slow the rate, maybe give an antihistamine like diphenhydramine before the next dose, and the patient can still receive vancomycin. Cold compresses only address surface symptoms without touching the underlying problem, which is the infusion speed. Here is a WGU D441 OA exam tip for you. When a red man syndrome question asks for the priority nursing action, the answer is always slow the infusion rate. The cause is speed, so the fix is speed. Quick recall hook. Red man equals slow the vancomycin rate down. 6. A nurse is caring for a patient on heparin therapy and notices that the patient has developed bleeding from the gums and easy bruising. The most recent lab work shows an elevated PTT. Which medication should the nurse anticipate administering as the specific antidote for this anticoagulant? A. Vitamin K supplement. B. Naloxone injection. C. Atropine sulfate. D. Protamine sulfate. What do you think is the answer? Correct answer, D. Protamine sulfate. Explanation: option D is correct because protamine sulfate is the specific antidote for heparin toxicity, as it directly binds to heparin molecules and neutralizes their anticoagulant effect, reversing the excessive bleeding risk. Option A is incorrect because vitamin K is the antidote for warfarin toxicity, not heparin, as warfarin works by inhibiting vitamin K-dependent clotting factors, while heparin works through a completely different anticoagulation mechanism. Option B is incorrect because naloxone is the antidote for opioid overdose and reverses respiratory depression caused by narcotics, having absolutely no effect on coagulation pathways or the anticoagulant activity of heparin therapy. Option C is incorrect because atropine sulfate is used to treat bradycardia and counteract the effects of cholinergic medications, and it has no role in reversing anticoagulant effects or managing heparin-related bleeding. Now we are dealing with heparin toxicity. The patient has gum bleeding, easy bruising, and an elevated PTT. That last part is the lab confirmation. PTT is the test you monitor for heparin. When it climbs too high, your patient is over-anticoagulated and bleeding. The specific antidote for heparin is protamine sulfate. Protamine physically binds to heparin molecules and neutralizes their anticoagulant activity. It is a direct chemical reversal. Vitamin K is the antidote for warfarin, not heparin. These two anticoagulants work through entirely different mechanisms, and their reversal agents do not swap. Naloxone reverses opioid overdoses and has zero effect on clotting. Atropine is for bradycardia, again nothing to do with coagulation pathways. Here is a WGU D441 OA exam tip for you. Antidote pairing is heavily tested. Lock these in. Heparin toxicity gets protamine sulfate. Warfarin toxicity gets vitamin K. When you see elevated PTT plus bleeding, think heparin, think protamine. Quick recall hook. Heparin and protamine are best friends, HP. They always go together. 7. A patient is being transitioned from heparin to warfarin therapy for long-term prevention of deep vein thrombosis. The nurse understands that the critical lab value to monitor regularly for patients on warfarin to ensure therapeutic levels and prevent bleeding complications is which of the following? A. PTT level every 6 hours. B. INR with a target of 2 to 3. C. Complete metabolic panel weekly. D. Serum potassium levels daily. What do you think is the answer? Correct answer, B. INR with a target of 2 to 3. Explanation. Option B is correct because the international normalized ratio with a therapeutic range of 2 to 3 is the standard lab value monitored for warfarin therapy to ensure proper anticoagulation and prevent dangerous bleeding. Option A is incorrect because PTT, or partial thromboplastin time, is the lab value specifically monitored for heparin therapy with a therapeutic range of 46 to 70, not for warfarin, which requires INR monitoring instead. Option C is incorrect because while a complete metabolic panel provides useful general health information, it is not the specific or targeted lab value used to monitor the therapeutic effectiveness and safety of warfarin anticoagulation therapy. Option D is incorrect because serum potassium monitoring is critical for medications like ACE inhibitors, spironolactone, or digoxin therapy, but it is not the primary lab value used for evaluating warfarin anticoagulation effectiveness. This question tests whether you can keep your anticoagulant lab values straight. The patient is transitioning from heparin to warfarin for long-term DVT prevention. Warfarin is the oral, slow-acting anticoagulant meant for the long haul. The lab test that monitors warfarin is the INR, and the therapeutic target for most patients is 2 to 3. That range means the blood is thin enough to prevent clots, but not so thin that the patient bleeds out. PTT is heparin's lab test, not warfarin's. The therapeutic PTT range for heparin is 46 to 70. A complete metabolic panel is useful general information, but it is not the targeted warfarin monitoring tool. Serum potassium is critical for drugs like ACE inhibitors or digoxin, not warfarin. Here is a WGU D441 OA exam tip for you. Keep your anticoagulant lab pairs straight. Heparin gets PTT 46 to 70. Warfarin gets INR 2 to 3. If the question says warfarin, the answer is INR. If it says heparin, the answer is PTT. Quick recall hook. WAR-INR, warfarin, and INR share those letters, WIN. 8. A patient asks the nurse whether their anticoagulant medication will dissolve the existing blood clot in their leg. Which response by the nurse demonstrates the most accurate understanding of how both heparin and warfarin function as anticoagulant therapies in clinical practice? A. They prevent new clots but do not dissolve existing ones. B. They slowly dissolve clots over several weeks. C. Heparin dissolves clots but warfarin does not. D. They dissolve clots only when given intravenously. Do you know the answer? Correct answer, A. They prevent new clots but do not dissolve existing ones. Explanation. Option A is correct because both heparin and warfarin function as anticoagulants that prevent the formation of new blood clots, but neither medication has the ability to dissolve clots that have already formed. Option B is incorrect because anticoagulants like heparin and warfarin do not dissolve existing blood clots at any speed, as thrombolytic agents are the class of medications specifically designed to break down already formed clots. Option C is incorrect because heparin does not dissolve blood clots regardless of its route of administration, as it works by enhancing antithrombin activity to prevent new clot formation rather than breaking down existing clot structures. Option D is incorrect because neither heparin nor warfarin dissolves existing blood clots through any route of administration, as their mechanism of action is strictly preventive, stopping new clots from forming rather than lysing existing ones. Patients ask this question all the time, and it gets tested because so many people misunderstand what anticoagulants actually do. Heparin and warfarin are anticoagulants. They prevent new blood clots from forming. They do not dissolve existing ones. The clot already sitting in that leg vein stays right where it is. The body breaks it down over time on its own through natural processes. If you wanted to actively dissolve an existing clot, you would need thrombolytic agents, which are a completely different drug class. No route of administration changes this fact. Heparin 4 does not dissolve clots. Warfarin oral does not dissolve clots. Neither one has clot-busting ability regardless of how you give it. They are purely preventive. Here is a WGU D441 OA exam tip for you. When a question asks whether heparin or warfarin dissolves clots, the answer is always no. They prevent new clots only. The word dissolve is the red flag. Quick recall hook, anticoagulants, anti-new clots. They fight the new ones, not the old ones. 9. A patient on warfarin therapy reports that they have been eating large amounts of leafy green vegetables this week. The nurse should be most concerned because a sudden increase in dietary intake of vitamin K could have which specific effect on this patient's anticoagulation therapy? A. Increase the risk of hemorrhage. B. Cause severe kidney damage. C. Decrease warfarin effectiveness significantly. D. Elevate the heart rate dangerously. What do you think is the answer? Correct answer, C. Decrease warfarin effectiveness significantly. Explanation. Option C is correct because warfarin works by inhibiting vitamin K-dependent clotting factors, so increasing dietary vitamin K intake counteracts warfarin's anticoagulant effect, reducing its therapeutic effectiveness and increasing clotting risk. Option A is incorrect because increased vitamin K intake would actually have the opposite effect of increasing hemorrhage risk, as more vitamin K promotes clotting factor production and counteracts the blood-thinning action of warfarin therapy. Option B is incorrect because dietary vitamin K from leafy green vegetables does not cause kidney damage, and the primary concern with increased vitamin K consumption during warfarin therapy is altered anticoagulation effectiveness, not organ toxicity. Option D is incorrect because changes in dietary vitamin K intake affect the coagulation cascade and warfarin's anticoagulant action, not cardiovascular parameters like heart rate, which is unrelated to the mechanism of warfarin therapy. This question tests the critical dietary interaction with warfarin. The patient has been eating large amounts of leafy green vegetables this week. Those greens are loaded with vitamin K. Here is the mechanism you need to remember. Warfarin works by blocking vitamin K-dependent clotting factors. So if the patient floods their body with extra vitamin K from food, they are directly counteracting the drug. More vitamin K means more clotting factors get produced, which means warfarin becomes less effective. The clotting risk goes up because the drug cannot do its job. Notice the question is not about hemorrhage. More vitamin K actually pushes the patient toward clotting, not bleeding. That is the opposite direction. Kidney damage and heart rate changes have nothing to do with the vitamin K and warfarin interaction. Here is a WGU D441 OA exam tip for you. When you see warfarin plus leafy greens or vitamin K intake, the concern is always decreased drug effectiveness. The patient is working against their own medication. Quick recall hook. K kills warfarin's power. Vitamin K counteracts warfarin. 10. A nurse is comparing heparin and warfarin for a patient education session. Which statement accurately describes a key clinical difference between these two anticoagulant medications that is essential for patient understanding about their long-term therapy plan and expectations? A. Heparin is taken orally at home. B. Warfarin works immediately upon ingestion. C. Heparin is used for lifelong therapy. D. Warfarin is slow-acting and used long-term. What do you think is the answer? Correct answer, D. Warfarin is slow-acting and used long-term. Explanation. Option D is correct because warfarin is a slow-acting oral anticoagulant prescribed for long-term or lifelong therapy to prevent conditions like deep vein thrombosis and pulmonary embolism in at-risk patients. Option A is incorrect because heparin is given intravenously or subcutaneously in clinical settings, not taken orally at home, as it is not effective through the oral route of administration. Option B is incorrect because warfarin is specifically known as a slow-acting anticoagulant that requires several days to reach therapeutic levels, which is why patients are often bridged with heparin initially during the transition period. Option C is incorrect because heparin is typically used as a short-term fast-acting anticoagulant in acute care settings, while warfarin is the anticoagulant prescribed for long-term or lifelong anticoagulation therapy and management. This is a patient education comparison question, and it wants you to know the key clinical differences between heparin and warfarin. The critical distinction is this: warfarin is slow-acting and meant for long-term use. It is taken orally and prescribed for ongoing prevention of DVT, PE, and stroke in at-risk patients. It takes several days to reach therapeutic levels, which is why patients get bridged with heparin initially. Heparin, by contrast, is fast-acting, given IV or subcutaneously, and used in acute care for short-term anticoagulation. It is not taken orally because it is not effective through the oral route. Heparin is not for lifelong therapy. Warfarin is, and warfarin definitely does not work immediately, so any option claiming instant effect is wrong. Here is a WGU D441 OA exam tip for you. When you see a question comparing heparin and warfarin, remember the speed and duration split. Heparin is fast and short, warfarin is slow and long. Quick recall hook: heparin is the sprinter, warfarin is the marathon runner. 11. A nurse is assessing a postoperative patient receiving morphine intravenously. The patient is difficult to arouse, has a respiratory rate of 10 breaths per minute, and blood pressure is dropping. Which phrase best summarizes the expected pattern of central nervous system effects associated with opioid medications? A. High and fast vital signs. B. Low and slow vital signs. C. Elevated temperature and alertness. D. Increased heart rate and anxiety. Can you guess the answer? Correct answer, B. Low and slow vital signs. Explanation: Option B is correct because opioids produce a characteristic pattern of low and slow effects, including low respiratory rate, low blood pressure, low heart rate, and central nervous system sedation, causing decreased arousal. Option A is incorrect because opioids cause depression of vital signs rather than elevation, as their mechanism of action suppresses the central nervous system, leading to decreased respiratory rate, blood pressure, and heart rate overall. Option C is incorrect because opioids do not cause elevated temperature or increased alertness, as their primary effect is central nervous system depression, resulting in sedation, drowsiness, and decreased responsiveness rather than heightened awareness. Option D is incorrect because increased heart rate and anxiety are associated with stimulant medications or sympathetic nervous system activation, not opioid use, which characteristically causes bradycardia, sedation, and respiratory depression instead. This question is about recognizing the fingerprint of opioid effects on the body. The patient received morphine IV postoperatively and now is hard to arouse, has a respiratory rate of 10, and blood pressure is dropping. Every single one of those findings points in the same direction, down. That is the opioid signature. The phrase you need is low and slow. Opioids depress the central nervous system, which means low respiratory rate, low blood pressure, low heart rate, and heavy sedation. Everything slows down and drops. High and fast vital signs are what you see with stimulants, not opioids. Elevated temperature and alertness are the opposite of what opioids do. Increased heart rate and anxiety sound like a sympathetic response or stimulant effect, not CNS depression. Here is a WGU D441 OA exam tip for you. When a question describes a patient on opioids and all the vitals are trending downward with sedation, the phrase is low and slow. That is the opioid pattern. Quick recall hook. Opioids go low and slow. Everything drops. 12. A nurse administers naloxone to reverse an opioid overdose. The patient initially responds but becomes unresponsive again after approximately 90 minutes. Which pharmacological principle best explains why this patient requires close reassessment and potentially additional doses of the reversal agent? A. Naloxone causes permanent receptor binding. B. The opioid was fully eliminated already. C. Naloxone increased the opioid effect. D. Naloxone has a short 1 to 2 hour half-life. Do you know the answer? Correct answer, D. Naloxone has a short 1 to 2 hour half-life. Explanation. Option D is correct because naloxone has a half-life of only 1 to 2 hours, which is often shorter than the opioid it is reversing, meaning the opioid effect can return and require additional naloxone doses at regular intervals. Option A is incorrect because naloxone does not permanently bind to opioid receptors, and its competitive antagonism is temporary with a short half-life, which is precisely why patients may need repeated doses when the reversal effect wears off. Option B is incorrect because if the opioid had been fully eliminated from the body, the patient would not become unresponsive again, and the return of symptoms indicates the opioid is still present and outlasting the naloxone effect. Option C is incorrect because naloxone is an opioid antagonist that blocks and reverses opioid effects rather than enhancing them, and the patient's return to unresponsiveness is due to naloxone wearing off, not increased opioid activity. This is a pharmacokinetics question disguised as a clinical scenario. The nurse gave naloxone to reverse an opioid overdose, the patient woke up, and then 90 minutes later they crashed again. Why? Because naloxone has a short half-life of only 1 to 2 hours. Most opioids, especially longer-acting ones, outlast naloxone. So what happens is the naloxone wears off while the opioid is still sitting on those receptors, and the overdose symptoms come roaring back. That is why patients who get naloxone need close monitoring and potentially repeated doses. It has nothing to do with permanent binding. Naloxone is a competitive antagonist, meaning it temporarily bumps the opioid off the receptor. The opioid was not eliminated either, because if it were, the patient would not have relapsed, and naloxone blocks opioid effects, it does not increase them. Here is a WGU D441 OA exam tip for you. Whenever a question describes naloxone wearing off and the patient declining again, the answer is the short half-life of naloxone. The opioid outlasts the reversal agent. Quick recall hook. Naloxone is a short shift worker. It clocks out in 1 to 2 hours. 13. A patient with chronic pain is prescribed a fentanyl transdermal patch. The nurse provides education about proper patch use. Which teaching point is most critical for the nurse to include when educating this patient about safe and effective use of the fentanyl patch? A. Always remove old patch before applying new. B. Expect immediate full pain relief. C. Use for acute post-operative pain only. D. Apply 2 patches for severe pain. What do you think is the answer? Correct answer, A. Always remove old patch before applying new. Explanation. Option A is correct because leaving an old fentanyl patch on while applying a new one creates a dangerous risk of overdose from doubled opioid absorption, so patients must always remove the previous patch before placement. Option B is incorrect because fentanyl patches have a slow onset and may take up to 17 hours to reach full therapeutic effect, so patients should not expect immediate pain relief upon initial application of the patch. Option C is incorrect because fentanyl patches are specifically indicated for persistent chronic pain management, not for acute post-operative or intermittent pain, as the delayed onset makes them inappropriate for rapid relief situations after surgery. Option D is incorrect because applying 2 fentanyl patches simultaneously without a prescription change creates extreme risk of respiratory depression and opioid overdose, as fentanyl is already one of the most potent available opioid medications. Fentanyl patches are powerful, and this question targets the most dangerous mistake a patient can make with them. The number 1 teaching point is this: always remove the old patch before applying a new one. If you leave the old one on, the patient now has 2 active fentanyl sources pumping opioid through the skin simultaneously. That is a fast track to overdose and respiratory depression. Fentanyl is already one of the most potent opioids available, so doubling the dose by accident can be fatal. The patch does not provide immediate relief either. It takes up to 17 hours to reach full effect, so patients need to understand that. Fentanyl patches are for chronic persistent pain, not for acute post-operative situations where you need fast onset, and applying 2 patches at once without a provider order is extremely dangerous. Here is a WGU D441 OA exam tip for you. Fentanyl patch questions almost always test the remove before replace rule. 2 patches on equals double dose equals overdose risk. Quick recall hook, 1 patch at a time, remove then replace, never stack. 14. A 75-year-old patient with chronic obstructive pulmonary disease is recovering from abdominal surgery performed 20 hours ago. The nurse recognizes this patient is at the greatest risk category for opioid-related death. Which combination of risk factors present in this scenario contributes most to that elevated danger level? A. Young age and high blood pressure. B. Female sex and history of diabetes. C. Advanced age, pulmonary disease and recent surgery. D. Low body weight and mild anxiety. What do you think is the answer? Correct answer, C. Advanced age, pulmonary disease and recent surgery. Explanation. Option C is correct because patients over 70 years old, those with underlying pulmonary diseases like COPD or asthma, and those within 24 hours after surgery face the highest risk of opioid-related respiratory failure and death. Option A is incorrect because young age is generally associated with lower opioid-related death risk compared to advanced age, and high blood pressure alone is not identified as a primary risk factor for fatal respiratory depression from opioid use. Option B is incorrect because while comorbidities matter in overall patient care, female sex and diabetes history are not specifically identified as the greatest risk factors for opioid-related death compared to advanced age and pulmonary disease combined. Option D is incorrect because low body weight and mild anxiety, while potentially relevant to dosing considerations, are not the primary high-risk factors for opioid-related death when compared to advanced age, pulmonary disease, and recent surgical status. This question wants you to identify the patient at greatest risk for opioid-related death. Look at what they are giving you, a 75-year-old with COPD, 20 hours after abdominal surgery. That is 3 major risk factors stacked on one patient. Advanced age over 70 means slower drug metabolism, greater sensitivity to respiratory depression. Pulmonary disease like COPD means the lungs are already compromised, so any further respiratory suppression from opioids becomes life-threatening faster. And being within 24 hours of surgery is the window where opioid-related respiratory failure peaks. Young age and high blood pressure, not the primary opioid death risk factors. Female sex and diabetes, relevant to general health but not the top tier for opioid respiratory failure. Low body weight and mild anxiety, worth considering for dosing, but they do not top the list when compared to this triple threat. Here is a WGU D441 OA exam tip for you. Opioid death risk questions are testing whether you can spot the triple threat. Age over 70, lung disease, and surgery within 24 hours. If all 3 are present, that patient is at the top of the danger list. Quick recall hook. Old lungs plus fresh surgery equals maximum opioid risk. 15. A patient using a patient-controlled analgesia pump asks their family member to press the medication delivery button because they are feeling too drowsy to push it themselves. Which response by the nurse is most appropriate to address this situation and ensure patient safety? A. Allow the family member to help. B. Only the patient may press the button. C. Disconnect the pump immediately now. D. Increase the dose for better relief. What do you think is the answer? Correct answer, B. Only the patient may press the button. Explanation. Option B is correct because patient-controlled analgesia is designed so that only the patient can self-administer doses, as drowsiness serves as a natural safety mechanism, preventing overdose when the patient falls asleep. Option A is incorrect because allowing a family member to press the patient-controlled analgesia button bypasses the critical built-in safety mechanism, potentially delivering opioid doses to an already sedated patient and increasing overdose and respiratory depression risk. Option C is incorrect because disconnecting the pump is an extreme response that removes the patient's pain management entirely, and the appropriate intervention is simply reinforcing that only the patient should operate the delivery button. Option D is incorrect because increasing the opioid dose for a patient who is already drowsy would dangerously elevate the risk of respiratory depression and central nervous system sedation, moving toward life-threatening opioid overdose rather than relief. Patient-controlled analgesia, or PCA, has a built-in safety feature that most people do not realize is part of the design. Only the patient should press the button. Here is why. If the patient is becoming too sedated from the opioid, they naturally fall asleep and stop pressing the button. The machine stops delivering doses. That drowsiness is the safety brake. When a family member presses it for a sleeping or drowsy patient, they override that brake. Now the machine delivers more opioid to someone who is already sedated, pushing them toward respiratory depression and overdose. Allowing the family member to help is dangerous. Disconnecting the pump entirely is too extreme and removes pain control. Increasing the dose for a drowsy patient would push them closer to overdose. The correct response is reinforcing that only the patient operates the button. Here is a WGU D441 OA exam tip for you. PCA questions almost always test the patient-only rule. Drowsiness is the built-in safety mechanism. If the patient is too drowsy to press the button, the system is working as designed. Quick recall hook. PCA equals patient controls always. Nobody else touches the button. 16. A patient on long-term lithium therapy for bipolar disorder presents with excessive urination, extreme thirst, vomiting, diarrhea, and hand tremors. The nurse reviews the most recent lithium level and finds it above 1.5. Which clinical conclusion should the nurse draw from these combined assessment findings? A. The patient is showing signs of lithium toxicity. B. The symptoms are expected therapeutic effects. C. The patient needs a higher lithium dose. D. These are signs of the medication non-compliance. Can you guess the answer? Correct answer, A. The patient is showing signs of lithium toxicity. Explanation. Option A is correct because lithium levels above 1.5 indicate toxicity, and excessive urination, extreme thirst, vomiting, diarrhea, and tremors are classic toxic signs that require immediate medical intervention and possible dose adjustment. Option B is incorrect because while some mild side effects can occur with lithium, the combination of excessive urination, extreme thirst, vomiting, diarrhea, and tremors with elevated levels represents toxicity, not expected therapeutic effects. Option C is incorrect because increasing the lithium dose when the level is already above 1.5 would be dangerous and potentially life-threatening, as these symptoms clearly indicate the current dose is causing toxic accumulation. Option D is incorrect because these symptoms with an elevated lithium level above 1.5 indicate the patient has too much medication in their system, suggesting toxicity rather than non-compliance with the prescribed treatment regimen. This question is all about recognizing lithium toxicity by matching symptoms to lab values. The patient has excessive urination, extreme thirst, vomiting, diarrhea, and hand tremors. The lithium level is above 1.5. That lab number alone tells you the story. The therapeutic range for lithium is 0.6 to 1.2. Anything above 1.5 is toxic territory, and the symptoms line up perfectly. Excessive urination and thirst, GI symptoms like vomiting and diarrhea, and neuromuscular symptoms like tremors are all classic lithium toxicity signs. These are not expected therapeutic effects. Mild side effects of lithium exist, but this combination with an elevated level crosses the line into toxicity. Increasing the dose would be dangerous when the level is already toxic, And these symptoms are the opposite of non-compliance, since the patient clearly has too much drug in their system. Here is a WGU D441 OA exam tip for you. Lithium toxicity questions always give you the level above 1.5 and a cluster of GI plus neuro symptoms. When you see that combination, it is toxicity. Quick recall hook, above 1.5 means lithium is alive with trouble. Toxic zone. 17. A patient on lithium therapy develops a stomach illness with severe vomiting and diarrhea lasting 3 days. The nurse recognizes that this gastrointestinal illness significantly increases the risk of lithium toxicity. Which physiological mechanism best explains why this patient is at particularly high risk during this illness? A. The illness increases lithium absorption rates. B. Vomiting destroys the lithium medication completely. C. Diarrhea increases kidney filtration speed. D. Dehydration and sodium loss concentrate lithium levels. Do you know the answer? Correct answer. D. Dehydration and sodium loss concentrate lithium levels. Explanation: Option D is correct because vomiting and diarrhea cause fluid loss and sodium depletion, and since lithium and sodium share renal reabsorption pathways, low sodium causes the kidneys to retain more lithium, increasing toxic concentration. Option A is incorrect because the gastrointestinal illness does not increase the rate of lithium absorption from the digestive tract, and the actual danger comes from dehydration and sodium loss, affecting how the kidneys handle lithium excretion. Option B is incorrect because vomiting does not destroy lithium molecules, and the medication that has already been absorbed into the bloodstream continues to circulate, with the real concern being that fluid and sodium losses concentrate existing lithium levels. Option C is incorrect because diarrhea and associated dehydration actually decrease kidney filtration effectiveness rather than increasing it, and the resulting sodium depletion causes the kidneys to reabsorb more lithium instead of excreting it properly. This question digs into the physiology behind why a stomach illness makes lithium so dangerous. The patient has been vomiting and having diarrhea for 3 days. That causes 2 things: dehydration and sodium loss. Here is the connection you need to understand. Lithium and sodium are handled by the kidneys in almost the same way. They share renal reabsorption pathways. When the body loses sodium through vomiting and diarrhea, the kidneys try to hold onto every sodium molecule they can. But because lithium and sodium look so similar to the kidney reabsorbs lithium right along with the sodium. The result is lithium levels climb while the body is dehydrated and sodium depleted. The illness does not increase lithium absorption from the gut, vomiting does not destroy lithium molecules, and diarrhea decreases kidney filtration, it does not increase it. Here is a WGU D441 OA exam tip for you. Any question linking dehydration, sodium loss, or GI illness to lithium is testing whether you understand the shared renal pathway. Low sodium means high lithium retention. Quick recall hook. Lithium follows sodium. Where sodium is low, lithium stays high. 18. A patient taking lithium asks the nurse whether it is safe to take ibuprofen for a recent headache. The nurse should advise the patient that non-steroidal anti-inflammatory drugs should be avoided during lithium therapy, primarily because of which specific and dangerous drug interaction risk. A. NSAIDs cancel out lithium's therapeutic effects. B. NSAIDs cause immediate allergic reactions. C. NSAIDs increase lithium levels and toxicity risk. D. NSAIDs lower blood pressure too rapidly. Do you know the answer? Correct answer: C. NSAIDs increase lithium levels and toxicity risk. Explanation: Option C is correct because non-steroidal anti-inflammatory drugs reduce kidney excretion of lithium, causing lithium levels to rise in the blood and significantly increasing the risk of developing dangerous lithium toxicity symptoms. Option A is incorrect because NSAIDs do not cancel the therapeutic mood-stabilizing effects of lithium, and the actual concern is the opposite problem where NSAIDs cause lithium to accumulate to dangerously high and toxic levels. Option B is incorrect because the interaction between NSAIDs and lithium is not an allergic reaction, but rather a pharmacokinetic drug interaction, where NSAIDs impair the kidney's ability to properly excrete lithium from the body. Option D is incorrect because the primary clinical concern with combining NSAIDs and lithium is not a rapid blood pressure decrease, but rather the dangerous accumulation of lithium to toxic levels caused by impaired renal lithium excretion. The patient is on lithium and wants to take ibuprofen for a headache. This is a classic drug interaction question. NSAIDs, which include ibuprofen, naproxen, and similar drugs, interfere with how the kidneys excrete lithium. Normally, the kidneys filter lithium out at a steady rate to keep levels in the therapeutic range. When you add an NSAID, the kidney's ability to clear lithium drops. Lithium accumulates in the blood and the level climbs into the toxic range. The danger is not that NSAIDs cancel lithium's mood-stabilizing effects. Actually, the opposite happens. Lithium levels go up, not down. It is not an allergic reaction either. This is a pharmacokinetic interaction, meaning one drug changes how the body handles the other. And the primary concern is not blood pressure changes. The real threat is lithium building up to toxic concentrations. Here is a WGU D441 OA exam tip for you. Whenever lithium and NSAIDs appear in the same question, the answer involves increased lithium levels and toxicity risk. NSAIDs block lithium excretion. Quick recall hook. NSAIDs trap lithium. They block the kidney exit door. 19. A nurse is educating a patient newly prescribed lithium about important dietary and hydration guidelines. Which instruction is most critical for the nurse to include to help the patient maintain safe therapeutic lithium levels and prevent toxicity during daily living? A. Do not limit sodium or fluid intake. B. Restrict all fluids to 1 liter daily. C. Avoid eating any salty foods completely. D. Drink only decaffeinated beverages exclusively. What do you think is the answer? Correct answer, A. Do not limit sodium or fluid intake. Explanation. Option A is correct because maintaining adequate sodium and fluid intake is essential during lithium therapy, as dehydration and low sodium cause the kidneys to retain more lithium, which dangerously increases the risk of toxicity. Option B is incorrect because restricting fluids to 1 liter daily would promote dehydration, and since lithium and sodium share kidney reabsorption pathways, inadequate fluid intake leads to dangerous lithium accumulation and increased toxicity risk. Option C is incorrect because completely avoiding salty foods would lead to sodium depletion, which is a direct contraindication during lithium therapy because low sodium levels cause the kidneys to retain more lithium and increase toxicity. Option D is incorrect because while caffeine moderation may be discussed in overall health teaching, the critical dietary instruction for lithium patients focuses specifically on maintaining adequate sodium and fluid intake to prevent dangerous toxicity. This is a patient education question about how to live safely while taking lithium every day. The most critical instruction is to not limit sodium or fluid intake. Lithium patients need to keep their salt and water intake consistent and adequate. Here is why this matters so much. Lithium and sodium share the same kidney reabsorption pathways. If the patient restricts fluids, dehydration pushes the kidneys to hold on to more sodium and lithium together, causing lithium levels to spike. If the patient cuts out salty foods entirely, sodium drops and the kidneys compensate by reabsorbing extra lithium. Both pathways lead to the same dangerous outcome, lithium toxicity. Restricting fluids to 1 liter is too little and promotes dehydration. Completely avoiding salt causes sodium depletion. And while caffeine moderation is reasonable general advice, the critical safety instruction for lithium is about sodium and fluids specifically. Here is a WGU D441 OA exam tip for you. Lithium dietary teaching questions are testing whether you know to maintain, not restrict sodium and fluid intake. Any answer that limits salt or water is wrong. Quick recall, hook. Lithium loves salt and water. Keep both flowing to keep lithium stable. 20. A patient on lithium therapy tells the nurse they feel much better and want to stop taking the medication. The nurse should educate the patient that abruptly discontinuing lithium is dangerous primarily because of which important clinical consideration about the nature of this medication therapy. A. Lithium cures bipolar disorder completely. B. Lithium requires consistent daily dosing long-term. C. Stopping causes immediate physical withdrawal. D. The medication can be restarted anytime easily. Do you know the answer? Correct answer B. Lithium requires consistent daily dosing long-term. Explanation: Option B is correct because lithium is a long-term maintenance medication for bipolar disorder that must be taken every day in regularly spaced doses, and discontinuation even when feeling well risks dangerous mood episode relapse. Option A is incorrect because lithium does not cure bipolar disorder, but rather manages and stabilizes mood symptoms, requiring ongoing consistent daily administration to maintain therapeutic levels and prevent the return of manic or depressive episodes. Option C is incorrect because the primary concern with stopping lithium is not immediate physical withdrawal symptoms, but rather the significant risk of bipolar mood episode relapse that can occur when therapeutic lithium levels drop below effective range. Option D is incorrect because restarting lithium after abrupt discontinuation is not a simple process, as it requires careful medical supervision, lab monitoring, and gradual dose titration to safely re-establish therapeutic blood levels without risking toxicity. The patient feels better and wants to stop lithium. This comes up constantly in clinical practice and on exams. Lithium does not cure bipolar disorder, it manages it. That means the patient needs to take it consistently every single day with regularly spaced doses for the long term. Feeling better is actually proof the medication is working, not a reason to stop. If the patient abruptly discontinues lithium, they lose the mood stabilization and the risk of a manic or depressive episode relapse shoots up significantly. This is not about physical withdrawal in the traditional sense. The main danger is psychiatric relapse, not withdrawal symptoms, and restarting lithium is not simple either. It requires medical supervision, lab monitoring, and gradual dose adjustment to safely get back to therapeutic levels without risking toxicity. Here is a WGU D441 OA exam tip for you. When a patient says they feel better and want to stop lithium, the answer is always about the need for consistent long-term daily dosing. Feeling good means the drug is working. Quick recall hook: feeling good equals drug working. Do not stop what is working. 21. A nurse is preparing to administer rapid-acting insulin Lispro to a patient before a meal. The nurse understands that the timing of food in relation to this insulin type is critical for preventing dangerous hypoglycemia. Which statement best describes the correct administration timing for rapid-acting insulin? A. Give 2 hours before the meal. B. Give at bedtime regardless of meals. C. Give 30 minutes after eating finishes. D. Give 15 minutes before eating or immediately after. What do you think is the answer? Correct answer, D. Give 15 minutes before eating or immediately after. Explanation: Option D is correct because rapid-acting insulin Lispro has a 15-minute onset, so it must be given just before or immediately after eating to match the insulin peak with food absorption and prevent dangerous hypoglycemia. Option A is incorrect because giving rapid-acting insulin 2 hours before a meal would cause the insulin to peak long before food is absorbed, resulting in severe and potentially life-threatening hypoglycemia without available glucose to counteract the effect. Option B is incorrect because rapid-acting insulin is specifically timed around meals to match its quick onset with food intake, and giving it at bedtime without food creates an extremely dangerous risk of nocturnal hypoglycemia. Option C is incorrect because waiting 30 minutes after eating to administer rapid-acting insulin allows blood glucose to spike unchecked and misaligns the insulin peak with digestion, compromising effective glucose management and control. Let's get into the timing of rapid-acting insulin, because getting this wrong can put a patient in serious danger. Rapid-acting insulin Lispro has an onset of about 15 minutes. That means it starts working fast. So the administration timing has to match. Give it 15 minutes before eating or immediately after. This way the insulin peak lines up with food absorption, and the glucose from the meal meets the insulin right on time. If you give it 2 hours before a meal, the insulin peaks long before any food hits the bloodstream. The patient crashes into hypoglycemia with no glucose available to save them. Giving it at bedtime without food is a recipe for nocturnal hypoglycemia, which is terrifying because the patient is asleep and cannot respond to their own dropping sugar. Waiting 30 minutes after eating misaligns the insulin peak with digestion and lets blood sugar spike unchecked first. Here is a WGU D441 OA exam tip for you. Rapid-acting insulin timing is 15 minutes before or immediately after meals. If the question says Lispro, Aspart, or Glulicine, think 15 and food. Quick recall hook, rapid equals right before the bite, 15 minutes before eating. 22. A nurse is drawing up a mixed insulin dose combining NPH and regular insulin in the same syringe. The nurse knows the correct technique requires drawing the insulins in a specific order to prevent contamination of the vials. Which principle should guide the nurse's preparation? A. Draw clear regular insulin before cloudy NPH. B. Draw cloudy NPH insulin before regular. C. Mix both insulins in a separate container. D. Always use 2 separate syringes instead. Do you know the answer? Correct answer, A. Draw clear regular insulin before cloudy NPH. Explanation. Option A is correct because the standard principle is to draw clear insulin before cloudy, meaning regular insulin is drawn first to prevent NPH particles from contaminating the regular insulin vial and altering its rapid action. Option B is incorrect because drawing cloudy NPH insulin first risks contaminating the regular insulin vial with NPH particles when inserting the needle back, which would alter the regular insulin's predictable onset and peak action times. Option C is incorrect because mixing insulin in a separate container is not standard nursing practice, and the accepted technique involves drawing both insulins sequentially into one syringe following the clear before cloudy principle for safety. Option D is incorrect because using 2 separate syringes for NPH and regular insulin when mixing is ordered increases patient discomfort with 2 injections and is not necessary when the proper clear to cloudy drawing technique is followed. Mixing insulins in the same syringe is a tested skill because the order matters. The rule is simple: draw clear before cloudy. Regular insulin is clear. NPH insulin is cloudy because it has particles suspended in the solution. You draw the clear regular insulin into the syringe first, then you draw the cloudy NPH. The reason is contamination prevention. If you drew the cloudy NPH first and then stuck that needle into the regular insulin vial, you would deposit NPH particles into the regular vial. Those particles would alter the regular insulin's predictable onset and peak, making future doses from that vial unreliable and potentially dangerous. Mixing in a separate container is not standard practice. Using 2 separate syringes means 2 injections, which is unnecessary discomfort when the mixing technique is done properly. Here is a WGU D441 OA exam tip for you. When you see a question about mixing insulin, the answer is always clear before cloudy. Regular first, NPH second. Quick recall hook. Clear before cloudy, like a clear sky before clouds roll in. R before N. 23. A nurse is caring for a patient in diabetic ketoacidosis who requires urgent insulin therapy through the intravenous route. The nurse knows that only one specific type of insulin is safe for intravenous administration. Which type of insulin is the only one approved and safe for intravenous use? A. NPH intermediate-acting insulin. B. Glargine long-acting insulin. C. Regular insulin only. D. Insulin Lispro rapid-acting type. Can you guess the answer? Correct answer, C. Regular insulin only. Explanation. Option C is correct because regular insulin is the only type approved for intravenous administration, making it the standard choice for managing diabetic ketoacidosis and other emergencies requiring precise and controllable insulin delivery. Option A is incorrect because NPH is an intermediate-acting insulin that should never be administered intravenously, as its suspension formulation is designed only for subcutaneous injection and could cause dangerous adverse reactions if given through IV. Option B is incorrect because glargine is a long-acting insulin with no peak that is designed exclusively for subcutaneous injection, and intravenous administration of glargine is contraindicated and potentially dangerous for the patient. Option D is incorrect because while insulin Lispro is rapid-acting and used subcutaneously around mealtimes, regular insulin remains the sole insulin type specifically indicated and approved for safe intravenous administration in clinical settings. This question comes up in every pharmacology course because it is a hard rule with no exceptions. Only regular insulin can be given intravenously. The patient is in diabetic ketoacidosis, which is a metabolic emergency. They need insulin delivered fast and in a way that can be precisely controlled. Regular insulin is the only type that is approved and safe for IV administration. Its formulation allows it to be infused directly into the bloodstream. NPH is an intermediate-acting insulin with a suspension that is designed only for subcutaneous injection. Pushing that into a vein could cause dangerous reactions. Glargine is long-acting with no peak, designed strictly for subcutaneous use. IV administration of glargine is contraindicated. Insulin Lispro is rapid-acting and used subcutaneously around meals, but it is still not the approved choice for IV delivery. Regular insulin is the one and only. Here's a WGU D441 OA exam tip for you. If the question involves IV insulin or DKA management, the answer is always regular insulin. No other type goes in the vein. Quick recall hook. Regular is the only regular on the IV team. Only one player allowed. 24. A nurse is educating a patient about their newly prescribed long-acting insulin glargine. The patient asks about how this insulin works differently from the other types they have heard about. Which characteristic most accurately describes long-acting insulin like glargine or detamir? A. Must be mixed with NPH insulin. B. Provides 24-hour coverage with no peak. C. Peaks within 30 to 90 minutes. D. Should only be given intravenously. Do you know the answer? Correct answer, B. Provides 24-hour coverage with no peak. Explanation. Option B is correct because long-acting insulins like glargine and detamir provide a steady 24-hour duration of action with no pronounced peak, offering consistent baseline glucose control throughout the entire day. Option A is incorrect because long-acting insulins like glargine must never be mixed with any other insulin type, as mixing would alter the formulation's unique prolonged absorption properties and compromise the consistent 24-hour coverage. Option C is incorrect because a peak of 30 to 90 minutes is characteristic of rapid-acting insulins like Lispro and Aspart, not long-acting insulins, which are specifically designed to have no discernible peak in their action profile. Option D is incorrect because long-acting insulins like glargine are administered only through subcutaneous injection, never intravenously, and regular insulin is the sole type of insulin approved and safe for intravenous administration in emergencies. The patient wants to understand how their new long-acting insulin glargine works differently from other types. Here is what makes glargine and detamir special. They provide a full 24 hours of coverage with no pronounced peak. That means a steady, flat baseline of insulin working all day and night. There is no sharp spike and crash. That consistency is what gives the patient stable blood sugar control around the clock. Glargine must never be mixed with any other insulin. Mixing would mess up the formulation and destroy that smooth 24-hour profile. A peak of 30 to 90 minutes belongs to rapid-acting insulins like Lispro, not long-acting ones. and glargine goes subcutaneously only. It is never given IV. Regular insulin is the only one for IV use. Here is a WGU D441 OA exam tip for you. Long-acting insulin questions test 3 facts: 24-hour duration, no peak, and never mix it. If you see glargine or detamir, those 3 facts are your answer keys. Quick recall hook: glargine is the flatliner. 24 hours, no peak, steady and smooth. 25. A diabetic patient on insulin therapy has a blood glucose reading of 62 and is showing signs of confusion, diaphoresis, and trembling. The nurse must quickly determine the most appropriate immediate intervention. Which action should the nurse take first to address this life-threatening hypoglycemic episode? A. Administer the next scheduled insulin dose. B. Check the patient's hemoglobin. A1C level. C. Recheck glucose in 30 minutes without intervening. D. Provide a fast-acting glucose source immediately. Do you know the answer? Correct answer D. Provide a fast-acting glucose source immediately. Explanation: option D is correct because a blood glucose of 62 with confusion and diaphoresis indicates dangerous hypoglycemia requiring immediate fast-acting glucose such as juice or glucose tablets to prevent seizures, coma, or death. Option A is incorrect because administering additional insulin to a patient with a blood glucose of 62 would further lower the already dangerously low blood sugar level, potentially causing seizures, loss of consciousness, or death. Option B is incorrect because hemoglobin A1C is a long-term blood sugar management indicator checked periodically, and it provides no useful information for managing an acute hypoglycemic emergency that requires immediate glucose intervention. Option C is incorrect because waiting 30 minutes to recheck glucose without intervening during active symptomatic hypoglycemia at 62 is dangerous, as the patient could rapidly deteriorate into seizures, unconsciousness, or cardiac arrest. The patient has a blood glucose of 62 with confusion, diaphoresis, and trembling. That is textbook symptomatic hypoglycemia, and it is a medical emergency. The priority action is to give a fast-acting glucose source immediately. Juice, glucose tablets, regular soda, anything that gets sugar into the blood fast. Every second counts because the brain is running out of fuel. Administering more insulin to a patient at 62 would drive the sugar even lower and could kill them. Checking hemoglobin A1C is a long-term management tool. It tells you about the last 3 months of sugar control. It does nothing for the patient crashing right now. Waiting 30 minutes to recheck without intervening is neglect during an active emergency. The patient could seize, lose consciousness, or go into cardiac arrest while you wait. Here is a WGU D441 OA exam tip for you. Anytime a question gives you a low blood sugar with symptoms like confusion, sweating, or trembling, the answer is immediate fast-acting glucose. Do not check labs, do not wait, do not give more insulin. Feed first. Quick recall hook: low and symptomatic equals sugar now, no delays. 26. A patient is newly prescribed captopril for hypertension and heart failure management. The nurse uses the mnemonic ACE to recall the most important adverse effects and precautions. Which set of findings correctly represents what the ACE mnemonic stands for when educating a patient about this ACE inhibitor? A. Anemia, anxiety, constipation, edema. B. Appetite loss, arrhythmia, cough, embolism. C. Avoid pregnancy, angioedema, cough, elevated potassium. D. Aspirin use, alkalosis, cramps, epistaxis. What do you think is the answer? Correct answer C. Avoid pregnancy, angioedema, cough, elevated potassium. Explanation: option C is correct because the ACE mnemonic for ACE inhibitors like captopril stands for avoid pregnancy, angioedema with swelling of face and tongue, persistent dry cough, and elevated potassium or hyperkalemia risk. Option A is incorrect because anemia, anxiety, constipation, and edema are not the primary adverse effects associated with ACE inhibitor therapy. and they do not represent what the ACE teaching mnemonic is designed to help nurses recall. Option B is incorrect because appetite loss, arrhythmia, and embolism are not the key side effects taught using the ACE mnemonic for captopril, and this combination does not reflect the established adverse effect profile of ACE inhibitor medications. Option D is incorrect because aspirin use, alkalosis, cramps, and epistaxis are not the recognized adverse effects captured by the ACE mnemonic, which specifically focuses on pregnancy risk, angioedema, cough, and elevated potassium levels. This question tests the ACE mnemonic for ACE inhibitors like captopril. ACE stands for 4 things you absolutely need to memorize. A is for avoid pregnancy. ACE inhibitors are teratogenic and strictly contraindicated in pregnant patients. A is for angioedema, which is swelling of the face, lips, and tongue that can obstruct the airway. C is for cough, a persistent dry cough that is one of the most common complaints patients have with ACE inhibitors. E is for elevated potassium, also called hyperkalemia, because ACE inhibitors cause the kidneys to retain potassium. The other answer options throw in random side effects like anemia, anxiety, arrhythmia, and alkalosis that are not part of the ACE profile for these drugs. Here is a WGU D441 OA exam tip for you. When you see captopril, lisinopril, or any drug ending in pril, think ACE. Avoid pregnancy, angioedema, cough, elevated potassium. Quick recall hook: ACE inhibitors have ACE problems. The letters practically spell it out for you. 27. A patient taking captopril has a potassium level of 5.8 and reports feeling dizzy when standing up from a seated position. The nurse recognizes these findings as 2 distinct but related complications of ACE inhibitor therapy. Which combination best explains both clinical findings occurring simultaneously in this patient? A. Hyperkalemia from potassium retention and orthostatic hypotension from blood pressure lowering. B. Hyperkalemia from potassium wasting and tachycardia. C. Hyponatremia from sodium retention and fluid overload. D. Hypocalcemia from calcium loss and muscle spasms. Do you know the answer? Correct answer: A. Hyperkalemia from potassium retention and orthostatic hypotension from blood pressure lowering. Explanation: Option A is correct because ACE inhibitors cause potassium retention, leading to hyperkalemia and lower blood pressure, which can result in orthostatic hypotension causing dizziness when the patient changes position from sitting to standing. Option B is incorrect because ACE inhibitors cause potassium retention and hyperkalemia rather than potassium wasting and hypokalemia, and tachycardia is not a primary expected side effect of captopril or other ACE inhibitor medications. Option C is incorrect because ACE inhibitors do not cause significant sodium retention or hyponatremia, and the patient's elevated potassium and positional dizziness are better explained by the drug's effects on potassium and blood pressure regulation. Option D is incorrect because hypocalcemia and muscle spasms are not associated with ACE inhibitor therapy, and the patient's potassium elevation and orthostatic dizziness clearly point to hyperkalemia and hypertension as the correct complications. The patient on captopril has a potassium of 5.8 and gets dizzy when standing. These are 2 separate complications happening at the same time, and both trace back to the ACE inhibitor. Potassium of 5.8 is hyperkalemia. ACE inhibitors block aldosterone, which normally tells the kidneys to dump potassium. Without that signal, potassium builds up. That is the E in ACE. The dizziness when standing is orthostatic hypotension. ACE inhibitors lower blood pressure by blocking angiotensin II, a powerful vasoconstrictor. When the patient shifts from sitting to standing, their blood pressure drops too fast and they feel lightheaded. Hypokalemia would mean potassium wasting, which is the opposite of what ACE inhibitors do. Hypernatremia and fluid overload do not match this drug's profile, and hypercalcemia has nothing to do with ACE inhibitor therapy. Here is a WGU D441 OA exam tip for you. When a question pairs high potassium with positional dizziness on an ACE inhibitor, You are looking at hyperkalemia plus orthostatic hypertension. Both are expected complications of the drug. Quick recall hook: ACE equals high K plus low standing BP, potassium up, pressure down when standing. 28. A nurse is reviewing the dietary education plan for a patient on captopril therapy. The patient enjoys eating bananas, oranges, and potatoes regularly. Which nursing instruction is most appropriate regarding this patient's diet while taking an ACE inhibitor to prevent dangerous electrolyte complications? A. Continue eating these foods without restriction. B. Increase intake of these potassium-rich foods. C. Eliminate all fruits and vegetables from diet. D. Limit potassium-rich foods to prevent hyperkalemia. What do you think is the answer? Correct answer: D. Limit potassium-rich foods to prevent hyperkalemia. Explanation: Option D is correct because ACE inhibitors like captopril increase potassium retention, so patients must limit high potassium foods like bananas, oranges, and potatoes to prevent dangerous hyperkalemia that could cause cardiac arrhythmias. Option A is incorrect because continuing unrestricted intake of potassium-rich foods while taking an ACE inhibitor significantly increases the risk of hyperkalemia, which can lead to life-threatening cardiac conduction abnormalities and arrhythmias. Option B is incorrect because increasing potassium-rich food intake would compound the potassium-retaining effect of ACE inhibitors, pushing potassium levels dangerously higher and creating a serious risk of cardiac complications from severe hyperkalemia. Option C is incorrect because eliminating all fruits and vegetables is nutritionally inappropriate and unnecessarily extreme, as the correct approach is to specifically limit high potassium foods while maintaining a balanced overall dietary intake pattern. The patient loves bananas, oranges, and potatoes. All three are loaded with potassium, and this patient is on captopril, an ACE inhibitor that already causes the body to retain potassium. So you have a drug holding on to potassium plus a diet pumping in more potassium. That combination drives potassium levels dangerously high, a condition called hyperkalemia. Severe hyperkalemia can cause life-threatening cardiac arrhythmias. The nursing instruction is to limit potassium-rich foods, not eliminate all fruits and vegetables, that is too extreme and nutritionally harmful, but specifically cut back on the high potassium items. Continuing without restriction ignores the compounding risk. Increasing intake of these foods would make the problem even worse. Here's a WGU D441 OA exam tip for you. ACE inhibitor plus diet questions are always testing potassium awareness. If the patient is eating bananas, oranges, potatoes, or tomatoes on an ACE inhibitor, the answer is limit potassium-rich foods. Quick recall hook: ACE plus banana equals bad. Limit the K-rich foods. 29. A patient on captopril asks the nurse which vital sign will be monitored most closely during follow-up appointments. The nurse explains that one particular measurement is the primary indicator of whether this medication is achieving its therapeutic goal effectively. Which vital sign is most important to monitor? A. Respiratory rate every shift. B. Blood pressure at each visit. C. Body temperature daily readings. D. Oxygen saturation continuously. Can you guess the answer? Correct answer: B. Blood pressure at each visit. Explanation: Option B is correct because captopril is an ACE inhibitor prescribed primarily to lower blood pressure in hypertension and heart failure, making blood pressure the most critical vital sign monitored to evaluate therapeutic effectiveness. Option A is incorrect because respiratory rate is not the primary vital sign used to assess the therapeutic effectiveness of ACE inhibitors, although respiratory assessment remains part of a comprehensive overall nursing assessment for all patients. Option C is incorrect because body temperature monitoring is not specifically relevant to evaluating captopril's therapeutic effect on blood pressure, as ACE inhibitors do not have a significant influence on the body's thermoregulation processes. Option D is incorrect because continuous oxygen saturation monitoring is not the primary parameter used to assess ACE inhibitor effectiveness, as the drug's therapeutic goal is specifically blood pressure reduction rather than improving oxygenation levels. This is a simple but commonly tested question about monitoring ACE inhibitor therapy. Captopril is prescribed for hypertension and heart failure. Its entire purpose is to lower blood pressure. So the most important vital sign to monitor is blood pressure at each visit. That is how you know the drug is working. If blood pressure is at target, the drug is doing its job. If it is still high, adjustments are needed. Respiratory rate is part of a standard assessment, but it is not the targeted indicator for ACE inhibitor effectiveness. Body temperature has nothing to do with how captopril works, and oxygen saturation, while valuable in many clinical situations, is not the parameter that tells you whether an ACE inhibitor is achieving its therapeutic goal. Here is a D441 OA exam tip for you. When the question asks which vital sign monitors ACE inhibitor effectiveness, the answer is blood pressure. The drug lowers BP, so you check BP. Quick recall hook. ACE lowers pressure, so you check pressure. Match the drug goal to the monitoring tool. 30. A pregnant patient arrives at the clinic and the nurse discovers she has been taking captopril prescribed by another provider for blood pressure management. The nurse recognizes an immediate safety concern. Which action should the nurse prioritize first in response to discovering this critically important patient situation? A. Increase the captopril dose for pregnancy hypertension. B. Add a potassium supplement to the regimen. C. Notify the provider immediately about the pregnancy. D. Schedule a follow-up in 2 weeks for monitoring. Do you know the answer? Correct answer, C. Notify the provider immediately about the pregnancy. Explanation: option C is correct because ACE inhibitors like captopril are strictly contraindicated in pregnancy due to risk of serious fetal harm, so the nurse must immediately notify the provider to discontinue the medication and arrange a safe alternative. Option A is incorrect because increasing the captopril dose during pregnancy would be extremely dangerous, as ACE inhibitors are contraindicated in pregnancy due to significant teratogenic risks, including fetal renal damage and developmental abnormalities. Option B is incorrect because adding a potassium supplement to captopril therapy would increase the already elevated risk of hyperkalemia, and this action completely ignores the critical priority concern of ACE inhibitor use during pregnancy. Option D is incorrect because scheduling a routine follow-up in 2 weeks is an inadequate response to discovering a pregnant patient on a contraindicated medication, as the teratogenic risk of ACE inhibitors requires immediate provider notification and intervention. A pregnant patient is taking captopril. That is a red alarm situation. ACE inhibitors are strictly contraindicated in pregnancy. The A in the ACE mnemonic stands for avoid pregnancy for exactly this reason. These drugs cause serious fetal harm, including renal damage and developmental abnormalities. The nurse must notify the provider immediately so the medication can be discontinued and a pregnancy-safe alternative can be arranged. Increasing the dose during pregnancy would be reckless and dangerous. Adding a potassium supplement on top of an ACE inhibitor compounds the hyperkalemia risk and completely ignores the pregnancy emergency. Scheduling a routine follow-up in 2 weeks is far too slow. Fetal harm from ACE inhibitors is not something that waits for convenience. Here is a D441 OA exam tip for you. Whenever pregnancy and an ACE inhibitor appear together in a question, the answer is always immediate provider notification. ACE plus pregnancy equals stop now, call now. Quick recall hook. Pregnant plus pril equals problem. Notify the provider immediately. 31. A patient arrives at the emergency department experiencing an acute asthma attack with severe wheezing and shortness of breath. The nurse knows the correct medication administration sequence follows the AIM protocol. Which medication should be administered first as the initial rescue intervention for this acute episode? A. Ipratropium nebulizer treatment. B. Oral montelukast tablet immediately. C. Methylprednisolone intravenous steroid. D. Albuterol rescue inhaler first. What do you think is the answer? Correct answer, D. Albuterol rescue inhaler first. Explanation: Option D is correct because the AIM protocol for acute asthma attacks specifies that albuterol, a beta-2 agonist rescue inhaler, should be administered first with 2 to 4 puffs every 20 minutes for 3 to 4 rounds. Option A is incorrect because ipratropium nebulizer is the second step in the AIM protocol for acute asthma management, and it should only be used after the initial albuterol rescue inhaler treatment has been administered to the patient. Option B is incorrect because montelukast is a preventive maintenance medication that takes 1 to 2 weeks to reach therapeutic effectiveness, making it completely inappropriate as a first-line rescue intervention during an acute asthma emergency. Option C is incorrect because methylprednisolone is an intravenous steroid that represents the third step in the AIM protocol sequence, and it should be administered only after albuterol and ipratropium have already been given to the patient. The patient rolls into the emergency department with an acute asthma attack, wheezing hard, struggling to breathe. The nurse needs to follow the AIM protocol, and the order matters. AIM stands for albuterol first, ipratropium second, methylprednisolone third. Albuterol is a beta-2 agonist rescue inhaler. It is the frontline rescue medication that opens the airways fast. You give 2 to 4 puffs every 20 minutes for 3 to 4 rounds. That is always step 1. Ipratropium nebulizer comes second after the albuterol has already started working. Montelukast is a preventive maintenance drug that takes 1 to 2 weeks to build up. Giving it during an acute attack is pointless. Methylprednisolone IV is the steroid that comes in at step 3 after the bronchodilators have been administered. Here is a WGU D441 OA exam tip for you. Acute asthma attack equals AIM protocol. A for albuterol first, I for ipratropium second, M for methylprednisolone third. The order never changes. Quick recall hook. AIM at the attack, AIM. Albuterol leads the charge. 32. A nurse is educating an athlete with exercise-induced asthma about preventive medication strategies before physical activity. The patient asks which medication should be taken before workouts to prevent bronchospasm from occurring during exercise. Which medication and timing should the nurse recommend for optimal prevention? A. Cromolyn 15 minutes before physical exertion. B. Methylprednisolone 1 hour before exercise. C. Montelukast immediately before running. D. Albuterol during the workout only. Can you guess the answer? Correct answer, A. Cromolyn 15 minutes before physical exertion. Explanation: Option A is correct because cromolyn is specifically indicated for preventing activity-induced asthma and should be taken 15 minutes before physical exertion to achieve maximum protective effect against exercise-triggered bronchospasm episodes. Option B is incorrect because methylprednisolone is a steroid used as the third step in acute asthma management, not a pre-exercise preventive medication, and its route and onset make it impractical for activity-induced asthma prevention. Option C is incorrect because montelukast is a long-term prevention medication that takes 1 to 2 weeks to reach full therapeutic effectiveness, so taking it immediately before exercise would provide no meaningful protective benefit against bronchospasm. Option D is incorrect because using albuterol only during the workout means waiting until bronchospasm has already started, which is a reactive rescue approach rather than the preventive strategy that is more appropriate for managing exercise-induced asthma. The athlete has exercise-induced asthma and wants to prevent bronchospasm before working out. The medication for this situation is cromolyn, taken 15 minutes before physical activity. Cromolyn works as a mast cell stabilizer that prevents the inflammatory cascade from triggering bronchospasm during exercise. It is specifically indicated for this exact scenario. Albuterol during the workout is reactive, not preventive. By the time you use a rescue inhaler during exercise, the bronchospasm has already started and you are playing catch-up. Methylprednisolone is an IV steroid used in step 3 of acute asthma management, not something you take before a jog. Montelukast is a long-term prevention drug that needs 1 to 2 weeks of daily use to work. Taking it right before exercise does nothing because it has not had time to build up. Here is a WGU D441 OA exam tip for you. Exercise-induced asthma prevention equals cromolyn 15 minutes before activity. If the question mentions an athlete or exercise and asks about prevention, cromolyn is the answer. Quick recall hook. Cromolyn before the crunch, 15 minutes before you move. 33. A patient has been using albuterol for an acute asthma episode and reports feeling their heart racing and having difficulty sleeping that night. The nurse should explain that these symptoms are related to which known pharmacological effect of this beta-2 agonist rescue medication. A. Central nervous system depression from the drug. B. Allergic reaction requiring discontinuation immediately. C. Expected side effects including tachycardia and insomnia. D. Signs of medication toxicity needing emergency care. Do you know the answer? Correct answer, C. Expected side effects including tachycardia and insomnia. Explanation. Option C is correct because tachycardia, palpitations, and insomnia are recognized expected side effects of albuterol as a beta-2 agonist, resulting from its sympathomimetic stimulation of the cardiovascular and nervous systems during use. Option A is incorrect because albuterol is a sympathomimetic beta-2 agonist that causes stimulatory effects like increased heart rate and alertness, not central nervous system depression, which would produce sedation and decreased responsiveness instead. Option B is incorrect because tachycardia and insomnia are well-documented expected pharmacological side effects of albuterol's beta-2 stimulation, not indicators of an allergic reaction that would typically present with rash, swelling, or breathing difficulty. Option D is incorrect because while tachycardia and insomnia can be uncomfortable, they are common known side effects of albuterol rather than signs of medication toxicity, which would present with more severe cardiac arrhythmias or dangerous symptoms. The patient used albuterol for an asthma episode and now has a racing heart and cannot sleep. These are not dangerous complications. These are expected side effects. Albuterol is a beta-2 agonist, which means it is a sympathomimetic. It mimics the sympathetic nervous system. While its target is the bronchial smooth muscle to open airways, the stimulatory effect leaks over into the cardiovascular and nervous systems. The result is tachycardia, palpitations, and insomnia. This is not CNS depression. Opioids cause depression. Albuterol is a stimulant. It is not an allergic reaction because allergic reactions show up as rash, swelling, and breathing problems. And it is not toxicity. Tachycardia and sleep trouble are common documented side effects that do not indicate a medical emergency. Here is a WGU D441 OA exam tip for you. Albuterol side effects questions test whether you know that tachycardia and insomnia are expected from beta-2 stimulation, not emergencies. Quick recall hook. Albuterol is a stimulant. Fast heart and wide awake are normal side effects. 34. A nurse is teaching a patient about Montelukast, a leukotriene receptor antagonist prescribed for long-term asthma prevention. The patient asks how quickly the medication will start working to control their asthma symptoms after they begin taking it daily. What is the most accurate response? A. Relief occurs within the first hour. B. Therapeutic effects take 1 to 2 weeks. C. Full benefit is achieved in 24 hours. D. Symptoms improve after the first dose immediately. Can you guess the answer? Correct answer, B. Therapeutic effects take 1 to 2 weeks. Explanation. Option B is correct because montelukast is a preventive asthma medication that takes 1 to 2 weeks of consistent daily use to reach full therapeutic effectiveness in controlling inflammation and preventing asthma attack episodes. Option A is incorrect because montelukast is not a rapid relief rescue medication and does not provide symptom improvement within the first hour, as its anti-inflammatory mechanism requires consistent daily dosing over 1 to 2 weeks for effectiveness. Option C is incorrect because achieving full therapeutic benefit from montelukast within 24 hours significantly underestimates the time required, as the medication's inflammation-preventing mechanism needs 1 to 2 weeks of regular use to work. Option D is incorrect because montelukast does not provide immediate symptom relief after the first dose like a rescue inhaler would, and patients must understand that consistent daily use for 1 to 2 weeks is necessary for therapeutic benefit. The patient just started montelukast and wants to know when it will kick in. The answer is not fast. Montelukast is a leukotriene receptor antagonist prescribed for long-term asthma prevention. It takes 1 to 2 weeks of consistent daily use to reach full therapeutic effectiveness. This is a slow-build medication that controls inflammation over time. It is not a rescue drug. You cannot take it and feel better in an hour. Expecting first-hour relief confuses montelukast with a rescue inhaler. Full benefit in 24 hours dramatically underestimates the time needed, and immediate improvement after the first dose does not happen with this class of drug. The patient needs to understand that they must take it every day and be patient for the build-up period. Here is a WGU D441 OA exam tip for you. Montelukast timing questions always test whether you know it takes 1 to 2 weeks. If the question asks about onset of effectiveness for montelukast, pick the longest reasonable option. Quick recall hook, Monty takes its sweet time, 1 to 2 weeks to work. 35. A patient using methylprednisolone intravenously during an acute asthma exacerbation has a blood glucose reading that has risen significantly above their baseline. The nurse understands this elevated glucose level is related to which pharmacological property of this corticosteroid medication used in step 3 of asthma management. A. Methylprednisolone directly damages pancreatic cells. B. The steroid causes fluid retention and kidney failure. C. Corticosteroids are known for causing hypoglycemia. D. Steroids increase glucose levels as a known effect. Do you know the answer? Correct answer, D. Steroids increase glucose levels as a known effect. Explanation. Option D is correct because corticosteroids like methylprednisolone are well known to increase blood glucose levels by promoting gluconeogenesis and reducing insulin sensitivity, which is an expected pharmacological effect during steroid therapy. Option A is incorrect because methylprednisolone does not directly damage pancreatic cells, and the elevated blood glucose results from the steroid's metabolic effects on glucose production and insulin resistance rather than organ destruction. Option B is incorrect because while corticosteroids can cause some fluid retention, the elevated blood glucose reading is specifically caused by the steroid's metabolic effects on glucose regulation, not by fluid retention or kidney failure mechanisms. Option C is incorrect because corticosteroids cause hyperglycemia rather than hypoglycemia, as their pharmacological action promotes glucose production in the liver and decreases cellular sensitivity to insulin throughout the body's tissues. The patient is on methylprednisolone IV during an asthma exacerbation, and their blood glucose just spiked above baseline. This is a well-known pharmacological effect of corticosteroids. Steroids increase blood glucose. They do this through two mechanisms: promoting gluconeogenesis in the liver and reducing how sensitive cells are to insulin. The result is blood sugar goes up. This is expected and needs to be monitored, but it is not a surprise finding. Methylprednisolone does not directly damage the pancreas. The glucose rise comes from metabolic effects, not organ destruction. Fluid retention can happen with steroids, but that is not why the glucose is elevated. And steroids cause hyperglycemia, not hypoglycemia. Getting that direction wrong is a common trap answer. Here is a WGU D441 OA exam tip for you. Steroids and blood sugar questions have one answer. Steroids raise glucose. Hyper, not hypo. If a patient is on any steroid and glucose goes up, that is the expected effect. Quick recall hook. Steroids equals sugar up. S and S. Steroids spike sugar. 36. A nurse is preparing to administer digoxin to a patient with heart failure. Before giving the medication, the nurse takes the patient's apical pulse for 1 full minute and obtains a reading of 54 beats per minute. Which nursing action is most appropriate based on this assessment finding? A. Administer the digoxin as prescribed. B. Hold the digoxin and notify the provider. C. Increase the dose per standing orders. D. Give the dose and recheck in 1 hour. What do you think is the answer? Correct answer B. Hold the digoxin and notify the provider. Explanation: Option B is correct because the standard nursing protocol requires holding digoxin when the apical pulse is below 60 beats per minute, as a low heart rate may indicate drug toxicity or dangerous cardiac depression risk. Option A is incorrect because administering digoxin when the apical pulse is 54, which is below the threshold of 60 beats per minute, could further depress heart rate and lead to dangerous bradycardia or cardiac conduction abnormalities. Option C is incorrect because increasing the digoxin dose when the patient already has a pulse below 60 beats per minute would be extremely dangerous, as this could worsen bradycardia and potentially lead to fatal cardiac arrhythmias or arrest. Option D is incorrect because giving the digoxin dose despite a below-threshold pulse reading violates the fundamental safety protocol, and rechecking in 1 hour does not prevent potential harm from administering the medication to a bradycardic patient. The nurse is about to give digoxin and checks the apical pulse for 1 full minute. The reading is 54. That is below 60, and 60 is the hard cutoff. Standard digoxin protocol is clear. If the apical pulse is below 60 beats per minute, you hold the dose and notify the provider. A pulse that low may indicate the drug is suppressing the heart rate too much, which could point to digoxin toxicity or developing bradycardia. Giving the digoxin at 54 would push the heart rate even lower and risk dangerous bradycardia or conduction abnormalities. Increasing the dose when the pulse is already below threshold could cause fatal arrhythmias, and giving the dose while planning to recheck later does not undo the harm of administering the drug to a bradycardic patient. Here is a WGU D441 OA exam tip for you. Digoxin pulse threshold is 60. Below 60 equals hold and notify. This is one of the most tested pharmacology facts. Memorize it cold. Quick recall hook. Dig under 60 equals dig it out. Hold the digoxin. Call the provider. 37. A patient on digoxin therapy reports nausea, loss of appetite, blurred vision, and confusion. Laboratory results reveal a potassium level of 3.2 and a magnesium level of 1.4. The nurse recognizes that these electrolyte imbalances are significant because they increase the risk of which dangerous complication? A. Respiratory failure from lung depression. B. Hepatotoxicity from liver enzyme elevation. C. Digoxin toxicity from low potassium and magnesium. D. Renal failure from kidney damage progression. Do you know the answer? Correct answer: C. Digoxin toxicity from low potassium and magnesium. Explanation: Option C is correct because hyperkalemia and hypomagnesemia significantly increase the risk of digoxin toxicity, and the patient's symptoms of nausea, vision changes, and confusion are classic signs confirming this dangerous drug-electrolyte interaction. Option A is incorrect because respiratory failure is not a primary complication of digoxin therapy or the electrolyte imbalances described, and the patient's symptoms of nausea, blurred vision, and confusion specifically point toward digoxin toxicity instead. Option B is incorrect because hepatotoxicity is not the primary concern with low potassium and magnesium levels in a patient taking digoxin, as these electrolyte deficiencies specifically enhance digoxin's cardiac toxicity rather than causing liver damage. Option D is incorrect because renal failure is not the complication most directly associated with hypokalemia and hypomagnesemia in digoxin therapy, and the patients presenting symptoms are classic indicators of digoxin toxicity rather than kidney dysfunction. This question layers digoxin toxicity signs on top of dangerous electrolyte imbalances. The patient has nausea, appetite loss, blurred vision, and confusion. Those are classic digoxin toxicity symptoms. Then look at the labs. Potassium is 3.2 and magnesium is 1.4. Both are low. Here is why that matters. Hypokalemia and hypomagnesemia amplify digoxin's effects on cardiac cells. When potassium is low, digoxin binds more aggressively to the sodium-potassium pump on heart cells. That increased binding intensifies the toxic cardiac effects. Low magnesium makes it even worse by further sensitizing the heart to digoxin. The symptoms plus the lab values together confirm digoxin toxicity driven by electrolyte deficiency. Respiratory failure, hepatotoxicity, and renal failure are not the complications linked to this specific drug-electrolyte interaction pattern. Here is a WGU D441 OA exam tip for you. Digoxin toxicity questions often pair GI and visual symptoms with low potassium and low magnesium. Low K plus low Mg plus digoxin symptoms equals toxicity. Quick recall hook, low K and low Mg make dig go toxic. Electrolytes feed the fire. 38. A nurse is educating a patient about self-monitoring while taking digoxin at home. The patient asks which assessment technique is most important to perform daily before taking the medication. Which instruction should the nurse provide as the highest priority for safe digoxin self-administration at home? A. Take your apical pulse for 1 full minute before each dose. B. Check your blood pressure twice daily after meals. C. Monitor your body weight every morning before breakfast. D. Count your respiratory rate for 30 seconds. What do you think is the answer? Correct answer, A. Take your apical pulse for 1 full minute before each dose. Explanation. Option A is correct because patients on digoxin must check their apical pulse for 1 full minute before each dose and hold the medication if the rate falls below 60 beats per minute to prevent dangerous bradycardia. Option B is incorrect because while blood pressure monitoring is valuable for overall cardiovascular health, the most critical daily self-assessment for digoxin safety is specifically the apical pulse rate to detect potential bradycardia before taking each dose. Option C is incorrect because daily weight monitoring is important for heart failure fluid management in general, but it is not the most critical self-assessment specifically tied to safe digoxin administration and preventing dose-related cardiac complications. Option D is incorrect because counting the respiratory rate is part of a general health assessment, but is not the specific priority monitoring parameter for digoxin therapy, which requires apical pulse measurement to detect heart rate changes indicating toxicity. This is a patient education question about self-monitoring at home on digoxin. The highest priority instruction is this: take your apical pulse for 1 full minute before every dose. If the pulse falls below 60, do not take the medication and call your provider. This is the same rule the nurse follows in the hospital, and the patient needs to know it for home safety. The 1 full minute part is critical because counting for only 15 or 30 seconds and multiplying introduces error, especially with an irregular heartbeat. Blood pressure twice daily is valuable for overall cardiovascular health, but it is not the specific safety check for digoxin. Daily weight monitoring matters for heart failure fluid management, but it is not the drug-specific priority. Respiratory rate counting is a general assessment parameter that does not tie directly to digoxin safety. Here is a WGU D441 OA exam tip for you. Digoxin home teaching always centers on apical pulse for 1 full minute before every dose. If the question asks about patient self-monitoring on digoxin, that is always the answer. Quick recall hook. Dig at home equals pulse first. 1 full minute every time. 39. A patient on digoxin therapy has a laboratory work drawn, and the nurse reviews the results to determine whether the patient is at increased risk for digoxin toxicity. Among the following electrolytes, which one is the most critical for the nurse to evaluate because its abnormal level most directly increases the danger of toxicity? A. Sodium level in the blood. B. Calcium level in the serum. C. Chloride level in the plasma. D. Potassium level in the blood. Do you know the answer? Correct answer, D. Potassium level in the blood. Explanation: option D is correct because potassium is the most critical electrolyte to monitor during digoxin therapy, as hyperkalemia directly increases the risk of digoxin toxicity by enhancing the drug's binding to cardiac cell receptors. Option A is incorrect because while sodium is an important electrolyte for overall fluid balance, it is not the primary electrolyte whose abnormal level most directly increases the risk of digoxin toxicity. Option B is incorrect because although hypercalcemia can contribute to digoxin sensitivity, potassium remains the most important and most frequently monitored electrolyte for preventing and detecting digoxin toxicity in clinical practice. Option C is incorrect because chloride levels are not a primary factor in determining digoxin toxicity risk, and the critical electrolytes that most directly influence digoxin toxicity are potassium and magnesium, rather than chloride plasma concentrations. Out of all the electrolytes to monitor during digoxin therapy, potassium is the big one. Potassium is the most critical because of how directly it affects digoxin's behavior at the cellular level. Digoxin works by inhibiting the sodium-potassium ATPase pump on cardiac cells. When potassium drops low, digoxin binds to that pump even more strongly. The result is enhanced drug effect, which sounds good until you realize that enhanced effect means enhanced toxicity. Hypokalemia and digoxin together create a perfect storm for dangerous cardiac arrhythmias. Sodium matters for fluid balance but does not directly amplify digoxin toxicity like potassium does. Calcium can contribute to digoxin sensitivity, but potassium is still the #1 priority on every clinical guideline. Chloride levels do not have a direct relationship with digoxin toxicity at all. Here is a WGU D441 OA exam tip for you. The electrolyte most linked to digoxin toxicity risk is potassium. Low potassium equals high digoxin danger. If the question asks which electrolyte to watch on DIG, pick potassium every time. Quick recall hook: K is the key to DIG safety. Watch the potassium. 40. A patient taking a statin medication for cholesterol management calls the clinic reporting severe muscle pain and dark cola-colored urine. The nurse recognizes these as potentially life-threatening signs of which serious adverse effect that requires immediate medical evaluation and possible discontinuation of therapy. A. Rhabdomyolysis causing muscle fiber breakdown. B. Hepatotoxicity causing liver enzyme elevation. C. Nephrotoxicity causing acute kidney injury. D. Anaphylaxis causing systemic allergic response. Do you know the answer? Correct answer, A. Rhabdomyolysis causing muscle fiber breakdown. Explanation: option A is correct because severe muscle pain combined with dark cola-colored urine are hallmark signs of rhabdomyolysis, a serious statin adverse effect where skeletal muscle fibers break down and release myoglobin into the bloodstream. Option B is incorrect because hepatotoxicity from statin therapy would present with jaundice, elevated liver enzymes, and abdominal symptoms rather than the characteristic combination of severe muscle pain and dark cola-colored urine seen in rhabdomyolysis. Option C is incorrect because while rhabdomyolysis can secondarily lead to kidney damage from myoglobin deposits, the primary adverse effect indicated by muscle pain and dark urine in a statin patient is rhabdomyolysis, not primary nephrotoxicity itself. Option D is incorrect because anaphylaxis presents with urticaria angioedema, respiratory distress, and cardiovascular collapse, not the specific combination of severe muscle pain and dark cola-colored urine that characterizes statin-induced rhabdomyolysis. The patient is on a statin for cholesterol and now has severe muscle pain plus dark cola-colored urine. That combination is a classic presentation of rhabdomyolysis. This is a serious adverse effect where skeletal muscle fibers break down and dump myoglobin into the bloodstream. The myoglobin turns the urine dark brown or cola-colored as the kidneys try to filter it out. The severe muscle pain comes from the actual muscle fiber destruction happening throughout the body. This is a medical emergency because the myoglobin can clog the kidneys and lead to acute kidney injury as a secondary complication. Hepatotoxicity from statins would show jaundice and elevated liver enzymes, not muscle pain and dark urine. Primary nephrotoxicity is a kidney problem, but the root cause here is muscle breakdown, not direct kidney attack. Anaphylaxis brings hives, swelling, and airway compromise, which is a totally different picture. Here is a WGU D441 OA exam tip for you. Statin plus severe muscle pain plus dark cola urine equals rhabdomyolysis. That is the only answer. The cola-colored urine from myoglobin is the giveaway detail. Quick recall hook: statin plus muscle pain plus cola P equals rhabdo. Remember the cola. 41. A patient with hepatic encephalopathy is prescribed lactulose. The nurse understands that this synthetic sugar achieves its therapeutic benefit through a specific mechanism involving ammonia removal. Which set of expected outcomes does the mnemonic LAC help the nurse remember when monitoring this patient's response to therapy? A. Liver repair, appetite increase, cardiac improvement. B. Low fever, antibiotic effect, cholesterol reduction. C. Laxative effect, ammonia decrease, cognition improvement. D. Lung function, albumin rise, calcium balance. Can you guess the answer? Correct answer C. Laxative effect, ammonia decrease, cognition improvement. Explanation: option C is correct because the Latin mnemonic for lactulose stands for laxative effect producing diarrhea, ammonia levels decrease as the liver clears this toxin, and cognition improves as ammonia is removed from the body. Option A is incorrect because lactulose does not directly repair liver tissue, increase appetite, or improve cardiac function, as its primary therapeutic mechanism involves reducing ammonia levels through the gastrointestinal tract to improve neurological status. Option B is incorrect because lactulose is not an antibiotic and does not reduce fever or cholesterol, as its mechanism involves trapping ammonia in the intestines and promoting its excretion through osmotic laxative-induced diarrhea. Option D is incorrect because lactulose does not improve lung function, raise albumin levels, or balance calcium, as its therapeutic action is specifically targeted at reducing ammonia levels in patients with hepatic encephalopathy through intestinal excretion. Let's talk about lactulose and the LAC mnemonic. The patient has hepatic encephalopathy, which means the liver is failing to clear ammonia from the blood. That ammonia builds up and crosses into the brain, causing confusion, altered mental status, and eventually coma. Lactulose is a synthetic sugar that fixes this problem through a specific three-step mechanism that the LAC mnemonic captures perfectly. L stands for laxative effect. Lactulose is an osmotic laxative that pulls water into the intestines and produces diarrhea. That diarrhea is not a side effect, it is the mechanism. S stands for ammonia decrease. Lactulose traps ammonia in the gut, and the laxative effect flushes it out through stool. C stands for cognition improvement. Once ammonia levels drop in the blood, the brain clears up and the patient's mental function improves. Lactulose does not repair liver tissue, boost appetite, or fix the heart. It is not an antibiotic and has nothing to do with cholesterol, lung function, albumin, or calcium. Here is a WGU D441 OA exam tip for you. Lactulose questions are testing the LAC mnemonic. Laxative, ammonia down, cognition up. If you see hepatic encephalopathy and lactulose, think LAC. Quick recall hook. LAC for lactulose. LAC. Laxative, ammonia, cognition. 42. A patient with a gastric ulcer is prescribed sucralfate and ask the nurse when to take the medication for maximum therapeutic benefit. The nurse knows that proper timing is critical for this mucosal protectant to work effectively. Which administration schedule should the nurse recommend to ensure optimal ulcer coverage? A. Take immediately after eating each meal. B. Take with a full glass of milk daily. C. Take once weekly on an empty stomach. D. Take on empty stomach 4 times daily and at bedtime. What do you think is the answer? Correct answer, D. Take on empty stomach 4 times daily and at bedtime. Explanation: Option D is correct because sucralfate must be taken on an empty stomach 4 times daily or at bedtime, allowing it to form a thick protective coating over the ulcer surface 1 to 2 hours before or after eating. Option A is incorrect because taking sucralfate immediately after eating would prevent the medication from forming an effective protective barrier over the ulcer, as food in the stomach interferes with the drug's ability to properly coat and shield the damaged area. Option B is incorrect because taking sucralfate with milk is not the recommended administration method, and the medication must be taken on an empty stomach to effectively form its protective coating over the ulcer without food interference reducing efficacy. Option C is incorrect because once-weekly dosing is far too infrequent for sucralfate to maintain consistent ulcer protection, as the medication requires multiple daily doses on an empty stomach to provide adequate and continuous coverage of the affected area. Sucralfate is a mucosal protectant for gastric ulcers, and the timing of this drug is everything. It has to be taken on an empty stomach 4 times daily and at bedtime. Here is why the empty stomach part is non-negotiable. Sucralfate works by forming a thick paste-like protective coating directly over the ulcer crater. Think of it like a bandage that sticks to the wound. For that coating to form properly and adhere to the ulcer surface, the stomach needs to be empty. Food in the stomach gets in the way and prevents the drug from making contact with the damaged tissue. Taking it immediately after eating defeats the entire purpose because the food blocks access to the ulcer. Taking it with milk interferes with the coating mechanism the same way, and once a week is nowhere near frequent enough since the protective barrier needs to be reapplied multiple times daily to maintain continuous coverage. Here is a WGU D441 OA exam tip for you. Sucralfate questions always test empty stomach and frequency. The answer is empty stomach 4 times daily and at bedtime. If food is mentioned in the same timing as the drug, that option is wrong. Quick recall hook: sucralfate needs a bare stomach, empty belly 4 times a day. 43. A patient on long-term non-steroidal anti-inflammatory drug therapy is prescribed misoprostol for gastric acid prevention. The nurse reviews the patient's chart and discovers the patient is a woman of childbearing age. Which critical safety concern should the nurse immediately address before this patient begins taking misoprostol for ulcer prevention? A. Risk of severe headaches and dizziness. B. Potential for fetal malformation and pregnancy loss. C. Danger of elevated blood pressure levels. D. Likelihood of severe constipation developing. Can you guess the answer? Correct answer, B. Potential for fetal malformation and pregnancy loss. Explanation: Option B is correct because misoprostol carries a high risk of fetal malformation, including clubfoot and cranial nerve abnormalities, and can also cause pregnancy loss, making pregnancy status verification absolutely critical before prescribing. Option A is incorrect because while headaches can occur with some gastrointestinal medications, the most critical safety concern with misoprostol for childbearing age women is its serious teratogenic potential and risk of causing miscarriage or fetal abnormalities. Option C is incorrect because elevated blood pressure is not the primary safety concern associated with misoprostol therapy, and the critical risk for women of childbearing age is the medication's well-documented ability to cause fetal malformation and pregnancy loss. Option D is incorrect because constipation is not a significant concern with misoprostol, and the critical safety issue that must be immediately addressed for childbearing age women is the serious risk of fetal malformation and spontaneous pregnancy loss. Misoprostol is prescribed to prevent gastric ulcers in patients on long-term NSAID therapy, but there is a massive safety concern that overrides everything else when the patient is a woman of childbearing age. Misoprostol is a prostaglandin analog, and prostaglandins stimulate uterine contractions. That means misoprostol can cause spontaneous abortion and pregnancy loss. On top of that, it carries a high risk of fetal malformation, including clubfoot and cranial nerve abnormalities. Before this drug is prescribed to any woman who could potentially be pregnant, pregnancy status must be verified. This is not optional. Headaches and dizziness are minor concerns that pale in comparison to fetal death and malformation. Elevated blood pressure is not the primary issue with this drug, and constipation is not even a relevant side effect of misoprostol. The pregnancy risk dominates every other consideration. Here is a WGU D441 OA exam tip for you. Misoprostol plus woman of childbearing age equals pregnancy safety concern. The answer is always about fetal malformation and pregnancy loss risk. Verify pregnancy status before prescribing. Quick recall, hook. Meso means missing pregnancy. Misoprostol can end a pregnancy. Check first. 44. A patient prescribed ferrous sulfate for iron deficiency anemia reports that their stools have become very dark and almost black in color. The patient is concerned this may indicate gastrointestinal bleeding. Which response by the nurse is the most appropriate and accurate explanation to address this patient's concern? A. Report to the emergency department immediately. B. This is a sign of internal gastrointestinal bleeding. C. Dark stools are a normal expected effect of iron. D. Stop taking the iron supplement right away. Do you know the answer? Correct answer C. Dark stools are a normal expected effect of iron. Explanation. Option C is correct because dark or black stools are a well-known and completely normal expected side effect of oral iron supplementation and do not indicate gastrointestinal bleeding, so the patient should continue taking the medication as prescribed. Option A is incorrect because sending the patient to the emergency department for dark stools caused by iron supplementation is an unnecessary and disproportionate response, as this discoloration is an expected pharmacological effect and not a medical emergency. Option B is incorrect because dark stools in a patient taking iron supplements are specifically caused by the iron itself changing stool color, and this expected side effect should not be confused with the dark tarry stools that indicate actual gastrointestinal bleeding. Option D is incorrect because discontinuing iron supplementation due to normal stool color changes would deprive the anemic patient of necessary treatment, and dark stools alone without other concerning symptoms do not warrant stopping the prescribed therapy. The patient is on ferrous sulfate for iron deficiency anemia and is alarmed because their stools turn dark, almost black. This is one of the most commonly asked patient questions about iron supplements, and it shows up on exams because the nurse needs to provide accurate reassurance. Dark or black stools are a completely normal and expected side effect of oral iron supplementation. The iron itself changes the color of the stool as it passes through the gastrointestinal tract. This is not gastrointestinal bleeding. Tarry stools from a GI bleed have a different consistency and smell compared to the simple color change from iron. The patient should continue taking the medication as prescribed. Sending them to the emergency department for a normal drug effect is a disproportionate response. Telling them it is GI bleeding would cause unnecessary panic and is factually wrong. And stopping the iron supplement deprives an anemic patient of treatment they need over a harmless cosmetic change in stool color. Here is a WGU D441 OA exam tip for you. Iron supplements plus dark stools equals normal expected effect. The patient needs reassurance, not alarm. Continue the medication. Quick recall hook. Iron turns it dark. Dark stools on iron are normal. Keep taking it. 45. A nurse is educating a patient about taking ferrous sulfate supplements for anemia treatment. The patient asks what they can take to help their body absorb the iron more effectively. Which supplement does the nurse recommend to enhance the absorption of oral iron taken on an empty stomach? A. Vitamin C to enhance iron absorption. B. Antacid medication before iron intake. C. Calcium tablets with each iron dose. D. Magnesium supplement at the same time. Do you know the answer? Correct answer: A. Vitamin C to enhance iron absorption. Explanation: Option A is correct because vitamin C enhances the absorption of oral iron supplements by converting ferric iron to its more absorbable ferrous form, though the two should not be taken at the exact same time together. Option B is incorrect because antacids block the absorption of iron and most other medications by altering stomach acidity, and patients should take iron at least 2 hours before or after any antacid medication to ensure proper absorption. Option C is incorrect because calcium products actually interfere with iron absorption rather than enhancing it, and patients should avoid taking calcium supplements or calcium-rich foods close to the time when they take their iron supplementation doses. Option D is incorrect because magnesium supplements do not enhance iron absorption and could potentially interfere with it, while vitamin C is the specifically recommended supplement that has been shown to improve the body's ability to absorb oral iron. The patient wants to know how to get the most out of their iron supplement. The answer is vitamin C. Vitamin C improves iron absorption by converting ferric iron into the ferrous form, which the body absorbs much more efficiently. Iron should be taken on an empty stomach for best absorption, and adding vitamin C to the regimen gives it an extra boost. Now, the substances that hurt iron absorption are just as important to know. Antacids alter stomach acidity, and iron needs an acidic environment to be absorbed properly. Taking an antacid before iron kills the absorption. Calcium directly competes with iron for absorption, so calcium tablets taken at the same time as iron reduce how much iron the body takes in. Magnesium supplements do not help iron absorption and could potentially interfere as well. Here is a WGU D441 OA exam tip for you. Iron absorption questions have a clean split. Vitamin C helps. Antacids, calcium, and magnesium hurt or do not help. If the question asks what improves iron absorption, the answer is always vitamin C. Quick recall hook: C boosts iron. Vitamin C is iron's best friend. 46. A patient who recently received a kidney transplant is taking cyclosporine to prevent organ rejection. The nurse knows this immunosuppressant requires monitoring of multiple organ systems for potential toxicity. Which combination of laboratory values should the nurse prioritize when monitoring for the most common adverse effects of cyclosporine therapy? A. Hemoglobin and hematocrit for anemia detection. B. Glucose and insulin levels for diabetes screening. C. Thyroid panel and cortisol for endocrine function. D. Creatinine and BUN for kidney plus AST and ALT for liver. Do you know the answer? Correct answer: D. Creatinine and BUN for kidney plus AST and ALT for liver. Explanation: Option D is correct because cyclosporine carries significant risks of both nephrotoxicity and hepatotoxicity, requiring regular monitoring of creatinine and BUN for kidney function and AST and ALT for liver function throughout the therapy. Option A is incorrect because while hemoglobin and hematocrit are important general labs, cyclosporine's primary organ toxicities affect the kidneys and liver, making creatinine, BUN, AST, and ALT the most critical monitoring parameters for this medication. Option B is incorrect because glucose and insulin monitoring are not the primary laboratory focus for cyclosporine therapy, as the medication's most dangerous adverse effects involve nephrotoxicity and hepatotoxicity rather than metabolic glucose dysregulation. Option C is incorrect because thyroid function and cortisol levels are not the priority monitoring parameters for cyclosporine therapy, as the drug's most significant toxicities target the kidneys and liver, requiring renal and hepatic function laboratory surveillance. Cyclosporine is an immunosuppressant given to transplant patients to prevent organ rejection. The patient just received a kidney transplant and now the nurse needs to know what labs to watch. Cyclosporine hits two organs hard, the kidneys and the liver. That means you need two sets of labs. For kidneys, you monitor creatinine and BUN. These tell you whether the kidneys are handling filtration properly or whether the drug is causing nephrotoxicity. For the liver, you monitor AST and ALT. These are liver enzymes that spike when hepatotoxicity develops. So the correct combination is creatinine and BUN for kidney function plus AST and ALT for liver function. Hemoglobin and hematocrit track anemia, which is not the primary cyclosporine toxicity target. Glucose and insulin are diabetes screening tools, not cyclosporine monitoring parameters. Thyroid panel and cortisol measure endocrine function that cyclosporine does not primarily affect. Here is a WGU D441 OA exam tip for you. Cyclosporine monitoring equals kidneys plus liver. Creatinine and BUN for one, AST and ALT for the other. 2 organs, 4 lab values, quick recall hook, cyclosporine hits the K and L, kidneys and liver, monitor both. 47. A patient taking carbamazepine for seizure management develops a fever and sore throat. Laboratory results show a significantly decreased white blood cell count. The nurse recognizes this combination of findings as an important adverse effect of carbamazepine. Which complication does this clinical presentation most likely represent? A. Normal therapeutic response to the medication. B. Allergic reaction requiring epinephrine immediately. C. Leukopenia increasing the risk of serious infection. D. Dehydration from medication-induced fluid loss. What do you think is the answer? Correct answer, C. Leukopenia increasing the risk of serious infection. Explanation. Option C is correct because carbamazepine commonly causes leukopenia, a decrease in white blood cells, which significantly increases the risk of infection, and fever with sore throat are early warning signs that must be reported immediately. Option A is incorrect because fever, sore throat, and decreased white blood cell count are not normal therapeutic responses to carbamazepine, but rather indicate the adverse effect of leukopenia, requiring prompt medical evaluation and possible dose adjustment. Option B is incorrect because while fever can occur in allergic reactions, the combination of a low white blood cell count with fever and sore throat specifically indicates carbamazepine-induced leukopenia rather than an acute allergic reaction requiring epinephrine. Option D is incorrect because the clinical presentation of fever, sore throat, and decreased white blood cells is characteristic of carbamazepine-induced leukopenia and immunosuppression, not dehydration, which would present with different laboratory and clinical findings. The patient is on carbamazepine for seizure management and develops fever, sore throat, and a low white blood cell count. That triad is the classic early warning sign of leukopenia, which is a well-known adverse effect of carbamazepine. Leukopenia means the white blood cell count has dropped, and white blood cells are the immune system's soldiers. With fewer of them, the patient becomes vulnerable to infections. Fever and sore throat are often the first clinical signs that the immune system is weakened. This combination must be reported immediately because it can progress to agranulocytosis, which is an even more severe and potentially fatal drop in white cells. These findings are absolutely not a normal therapeutic response. Carbamazepine is supposed to control seizures, not tank the immune system. It is not an allergic reaction because the lab finding of low white cells points specifically to bone marrow suppression, not an immune-mediated allergy. And dehydration would show different labs entirely and does not cause a white cell drop. Here is a WGUD 441 OA exam tip for you. Carbamazepine plus fever plus sore throat plus low WBC equals leukopenia. That specific cluster is the tested pattern. Report immediately, quick recall hook. Carba kills white cells. Fever and sore throat are the alarm bells. 48. A patient taking allopurinol for gout prevention develops a mild skin rash and contacts the clinic. The nurse must advise the patient on the appropriate immediate response because even a mild rash with this medication can indicate a potentially fatal dermatologic reaction. Which instruction should the nurse give this patient? A. Stop the medication and report to the provider immediately. B. Apply hydrocortisone cream and continue the medication. C. Take an antihistamine and monitor for improvement. D. Increase fluid intake and ignore the mild rash. Can you guess the answer? Correct answer: A. Stop the medication and report to the provider immediately. Explanation: Option A is correct because even a mild rash during allopurinol therapy can be an early warning sign of Stevens-Johnson syndrome, a potentially fatal dermatologic emergency that requires immediate medication, discontinuation, and urgent provider notification. Option B is incorrect because applying topical cream and continuing allopurinol when a rash appears ignores the potentially life-threatening risk of Stevens-Johnson syndrome, which requires immediate drug cessation rather than symptomatic treatment of the skin. Option C is incorrect because taking an antihistamine and monitoring does not address the serious risk that even a mild rash on allopurinol could represent the early stage of Stevens-Johnson syndrome, which demands immediate discontinuation and medical evaluation. Option D is incorrect because ignoring a rash while taking allopurinol is extremely dangerous, as this could allow progression to Stevens-Johnson syndrome, a potentially fatal condition where the skin and mucous membranes develop severe blistering and detachment. The patient is on allopurinol for gout prevention and develops a mild skin rash. This might sound minor, but with allopurinol, even a mild rash can be the opening act for Stevens-Johnson syndrome. Stevens-Johnson syndrome is a potentially fatal dermatologic emergency where the skin and mucous membranes develop severe blistering and start detaching from the body. It can kill. The rash is the early warning, and the window to act is before it progresses. The instruction is clear: stop the medication immediately and report to the provider right away. Applying hydrocortisone cream and continuing the drug ignores the life-threatening risk sitting underneath that mild rash. Taking an antihistamine and monitoring wastes precious time when the priority is stopping the drug that could be triggering a fatal reaction. And ignoring the rash while continuing allopurinol could allow full progression into Stevens-Johnson syndrome with massive skin loss. Here is a WGU D441 OA exam tip for you. Allopurinol plus any rash, even mild, equals stop the drug and call the provider. Stevens-Johnson syndrome is the reason. Do not treat the rash. Stop the cause. Quick recall hook. Allo rash equals all stop. Any rash on allopurinol means stop everything and call. 49. A patient taking a monoamine oxidase inhibitor for treatment-resistant depression eats a meal containing aged cheese, red wine, and cured meats. Shortly after, the patient develops a severe headache, stiff neck, and dangerously elevated blood pressure. Which serious complication has this patient most likely experienced from the dietary interaction? A. Serotonin syndrome from excess serotonin. B. Anaphylactic shock from food allergy. C. Neuroleptic malignant syndrome from overheating. D. Hypertensive crisis from tyramine-rich foods. Do you know the answer? Correct answer: D. Hypertensive crisis from tyramine-rich foods. Explanation: Option D is correct because MAOIs prevent the breakdown of tyramine found in aged cheese, red wine, and cured meats, causing dangerous accumulation that triggers a hypertensive crisis with severe headache and critically elevated blood pressure. Option A is incorrect because serotonin syndrome results from combining serotonergic medications rather than from dietary tyramine intake, and its presentation includes hypothermia, agitation, and clonus, rather than the isolated severe hypertension described here. Option B is incorrect because anaphylactic shock from food allergy, would present with urticaria, angioedema, respiratory distress, and hypertension, which is distinctly different from the hypertensive crisis with severe headache caused by tyramine-MAOI interaction. Option C is incorrect because neuroleptic malignant syndrome is caused by dopamine-blocking antipsychotic medications and presents with hypothermia, muscle rigidity, and autonomic instability, not the dietary tyramine-induced hypertensive crisis seen with MAOI therapy. This is one of the highest yield pharmacology questions you will ever encounter. The patient is on an MAOI for treatment-resistant depression and ate a meal loaded with tyramine, aged cheese, red wine, and cured meats. Now they have a severe headache, stiff neck, and dangerously elevated blood pressure. This is a hypertensive crisis caused by tyramine accumulation. Here is the mechanism. MAOIs block the enzyme monoamine oxidase, which normally breaks down tyramine in the gut. When that enzyme is blocked, tyramine from food enters the bloodstream unchecked. Tyramine then triggers a massive release of norepinephrine, which slams blood pressure through the roof. The result is a hypertensive crisis that can cause stroke, brain hemorrhage, or death. Serotonin syndrome comes from combining serotonergic drugs, not from food. Anaphylaxis would show hives, swelling, and low blood pressure, not high blood pressure. Neuroleptic malignant syndrome is caused by antipsychotics, not MAOIs, and food.
Here is a D441 OA exam tip for you. MAOI plus aged cheese, wine, or cured meats plus severe headache and high BP equals hypertensive crisis from tyramine. The food list is the giveaway. Quick recall hook. MAOI plus tyramine equals BP through the roof. Cheese, wine, and meats are the triggers.
50. A patient on theophylline therapy for asthma management has a serum drug level reported at 22. The nurse also notes the patient is consuming large amounts of coffee daily and taking atenolol for blood pressure control. Which combination of concerns should the nurse prioritize when evaluating this patient's current medication and lifestyle profile? A. Theophylline level is within safe therapeutic range. B. Coffee and atenolol are both safe with theophylline. C. Toxic drug level plus caffeine and beta blocker interaction risks. D. Only the coffee intake needs to be addressed here. Do you know the answer? Correct answer, C. Toxic drug level plus caffeine and beta blocker interaction risks. Explanation: Option C is correct because a theophylline level over 20 is toxic, caffeine increases theophyline's stimulatory cardiac effects, and beta blockers like atenolol are contraindicated with theophylline, creating multiple dangerous interaction risks simultaneously. Option A is incorrect because a theophylline level of 22 exceeds the safe therapeutic threshold of 20, placing this patient in the toxic range with increased risk of tonic-clonic seizures, tachycardia, and other serious cardiac complications. Option B is incorrect because both caffeine and beta blockers like atenolol are specifically identified as substances to avoid during theophylline therapy, as caffeine enhances toxicity risk and beta blockers create dangerous pharmacological conflicts with the medication. Option D is incorrect because addressing only coffee intake ignores the critically elevated theophylline level above 20 and the dangerous interaction with the concurrent beta blocker atenolol, both of which pose serious and immediate patient safety risks. This final question throws 3 problems at you simultaneously, and you need to catch all of them. The patient is on theophylline for asthma, the serum level is 22, they are drinking large amounts of coffee, and they are taking atenolol for blood pressure. Problem 1, the theophylline level. The therapeutic range is 10 to 20. A level of 22 is above 20, which means the patient is in the toxic range. Toxic theophylline levels put the patient at risk for tonic-clonic seizures, tachycardia, and serious cardiac complications. Problem 2, caffeine. Theophylline and caffeine are both methylxanthines. They amplify each other's stimulatory effects on the heart. Heavy coffee intake on top of an already toxic theophylline level is pouring gasoline on a fire. Problem 3, Atenolol is a beta blocker, and beta blockers are contraindicated with theophylline because they create dangerous pharmacological conflicts. Saying the level is safe ignores that 22 exceeds the threshold. Saying both coffee and atenolol are fine ignores 2 documented drug interactions. And addressing only coffee misses the toxic level and the beta blocker problem. Here is a WGU D441 OA exam tip for you. Theophylline questions test 3 things. Is the level above 20? Is the patient drinking caffeine? Are there contraindicated medications? Check all 3. Quick recall hook. Theo has 3 enemies: toxic levels, caffeine, and beta blockers. Watch for all 3. You have reached the end of our first question set. For the free complete exam preparation, visit our website, link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.